and kick it off.
All right,
Good morning. Welcome, everyone. My name is Brenda Johnson. I use she, her pronouns, and I'm chairing today's Oregon Health Policy Board meeting. Welcome. Just to do a bit of housekeeping, the agenda for today, the Zoom chat feature in today's meeting only allows the meeting attendees to message the host and the co-host and no other meeting participants. Any questions, thoughts, or comments can be sent via Zoom chat to the meeting co-host, which is Tara Cheetak. And if you have any supporting resource link you'd like to share with the meeting participants regarding any agenda item that's currently being discussed, please feel free to share that link with the meeting host or co-host, and we'll pass it out to the rest of the meeting attendees. All materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked to today's meeting agenda as well. So with that, we'll turn to Tara to support us in roll call. Tara, go ahead.
Thank you. Good morning, board members. I'll start with Brenda Johnson. Kirsten Isaacson.
Good morning.
Tony German.
Good morning, everybody. Present.
Melina Moran.
Present. Good morning.
Bill Kramer.
Present. Good morning.
Dr. Hemmings.
Here. Good morning, everyone.
Harley Hood-Ronick.
Good morning, present.
And Peter Starkey. And I know Peter may be joining us by phone, but he did give me a heads up. He probably won't be here today, but I'll make a call. Peter, are you there? Okay, I don't hear Peter. We have 7 of 8 members for quorum.
Thank you, Tara. Next up, I'd love to read the health equity definition for us this month. As we know, each month a board member takes turn reading the definition. So this month it's mine. So to ground us in our work in health equity, this definition, of course, has a lot of profound meaning to this board. I don't know, Tara, if you want to, pull it up on the screen as well. So our definition, Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Again, let us use this definition and these principles as we guide our discussions, and it's certainly in your board packet materials. We'll start off with a welcome and really spent this first half hour with a bit of our board business. We'll review a metrics statement that Kirsten and Peter have reviewed for us and work also with our Health Equity Committee action letters, and our liaisons will give us an update on some ideas about that as well. We'll then turn to Dr. Hathi, who will give us an Oregon Health Authority update. We'll hear presentations from our Healthcare Workforce Committee, and they have a robust charter for our approval and attention before we move to public comment, or rather break, and then a public comment. We'll then spend a good chunk of time with our Healthcare Cost Target Advisory Committee. They both have membership appointments and kind of a future view of what our June board meeting may look like relative to our public hearings. Last and certainly not least, we'll have a presentation from our Health Information Technology Oversight Council, or HITAC. Thank you to all of you who were able to either attend the webinar or watch its recording in advance of this presentation today. We put a lot of time and energy into the strategic plan, and they also have a request for us for proposed membership update. And that looks like our agenda for the day. Next up, we'll actually look at our last month's board meeting minutes. So to vote on the draft of April 2024, Draft minutes are provided in our packet as attachment 1.0. And I know you've had time to review that, but if someone is so moved to offer approval motion, that'd be really helpful. So who'd like to move approval?
So moved. This is Bill.
Thanks.
Second, Carly.
Thanks. It's been moved and seconded. Is there discussion? Hearing none. All those in favor signify by saying aye.
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 Any opposed? Great, motion carries. Okay, next up, just some board business. At our April board meeting, you'll recall that our illustrious team of liaisons and leaders held and facilitated by Kirsten recommended that we consider publishing a public statement in support of centering the CCO Metrics Incentive Program on health equity. We reviewed the first draft at our April board meeting, and at that time suggested that board members could offer edits, which they did over the last month. And Kirsten and Peter worked together primarily to update that draft statement language. It is also included in our material packets as 1.1. And Kirsten and Peter, Kirsten, since Peter's not here, Kirsten, would you introduce the topic and offer any adjustments that you want to make for today? Thanks.
I will. Thank you so much for the introduction. I think I heard a lot of what I was going to kind of walk us back through. So that was great. That the aim of this is to create kind of a North Star high-level statement to really anchor our board and send a clear message to the Oregon Health Authority and others regarding the evolution of this quality incentive program. And so the primary goal is to really underscore centering health equity as the Metrics Quality Incentive Program goes through this study and potential changes. So with input from you all over the past many weeks, Peter and I worked on this draft statement. I'll read it because I want to make sure everybody hears it. I'll read it aloud so people can hear it. It's also in our packet for those of us that do better reading. And thank you for putting it in the text, Tara. And I will highlight there was a small change from what was in our packets this morning versus what came to us last week. And so that is what's bolded and underlined just for super clear transparency there. It's a good edit. So the Oregon Health Policy Board believes the Coordinated Care Organization Quality Incentive Program should be centered around the goal of eliminating health inequities. To do this, the program must be informed by the voices most impacted, particularly Oregon Health Plan members. Financial incentives should promote the work of those who are making bold, measurable progress towards eliminating health inequities and are best positioned to implement effective interventions. Reducing health inequities requires addressing social drivers of health and collaborating inside and outside of clinical walls and systems. Bold, measurable progress should involve collaboration between CCOs, providers, systems, and communities most impacted. By incentivizing collective action towards tackling health inequities, OHPB's aim is to create a more comprehensive, sustainable system and improve health outcomes for us. And so that's the statement. I want to give a lot of appreciation to the feedback that everyone gave, and particularly for Peter really getting in there and writing and wordsmithing. It was lovely to collaborate with him. So with that is our statement that I would like to propose we adopt today. Any questions or discussions?
Tony, go ahead.
Yeah, I just really wanted to thank Kirsten and Peter for their work on this wordsmithing, and I think the outcome of what we have in front of us is really, really excellent. I just think I wanted to call out. I had some conversations with Kirsten and Peter about this and doing this, and I think it just needs to be highlighted, a couple of phrases in here, and I think the underscore is great. But us rethinking how we're approaching healthcare and eliminating health inequity. And I think the line, those that are best positioned to implement effective interventions, and thinking that our classic to healthcare inside clinic walls isn't going to get us there. And so I just really appreciate the wording that you guys put in that, and understanding that the broader scope and our team members really that we're engaging with across the greater landscape of healthcare, including community-based organizations, again, outside clinic walls, is how I think we're going to attain that. So I just really appreciate your guys' work on that, and so thank you.
Thank you, Tony. Other reactions or input? I'll just echo a few words, Kirsten, if you don't mind. I'll lean in and just, I also commend the work that went into this. I think the principles behind it are solid. And, I think about the implications of statements like this and what it'll actually mean to communities, what it'll mean to the CCOs and the systems that are responsible for garnering this body of work, and kind of the investments or the creative investments that may follow. So I think it sets course, for a specific direction. And I think it'll be incumbent on us and those that touch this statement to be thinking about how to implement it in ways that are really thoughtful and community driven. Even echoing Tony, your comment about those best positioned to implement. And I can think about fragile ecosystems, that are adjacent to or directly intersecting with healthcare systems that require different orientations and support in order to think differently, report differently, manage resources differently. And I know across the state, we learned a lot during COVID about how powerful many of our community-based organizations are and always have been in being able to impact community. And so knowing that this is a different orientation to a certain extent, it's a shift toward a different approach. I think it's important to acknowledge the significance of it. So thanks for the time on it. And I just want to say all that out loud. Yeah.
Spot on. And I think we will have I expect many opportunities this fall for us to be revisiting this and thinking of exactly how we are implementing this. Well, then, with deep appreciation for all, and I hope each of you sees phrases that you may have said actually in here in particular. So the wordsmithing was inspired by all of you. I would like to move that the Health Policy Board adopt this metric statement.
Thank you, Kirsten. Is there a second to this motion?
Second, Tony.
Thanks, Tony. Any other discussion, questions, considerations from the board? Okay, seeing and hearing none, all those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? Any abstentions? Okay, motion carries. Thank you so much, Kirsten, for your hard work and leadership in it too. Shirley, go ahead. Oops, I can't hear you yet.
Okay, I think
There
I've
you
got
go.
it off mute at this point. Thanks,
There
Brenda.
you go. Thanks.
I just wanted to reflect for a moment for the board members on what kind of action this statement might lead to. And certainly this is a very important action, just adopting the statement and communicating it to the committee. And just to remind folks that historically the legislature has been very interested in hearing from the board, and particularly on this issue. And so I'm very gratified to see you all setting a North Star, ground yourself in principles for the program. And I think that lays a good foundation to be prepared to speak on it if that's necessary, if there is legislation or further action on this issue. So really really appreciative on this and the board on having a good foundation here.
Thanks so much, Charlie. Thank you for that. Okay, next up, we'd love to have a discussion in follow-up to our April board meeting as well, where, if you recall, our Health Equity Committee presented two key action letters for our consideration and support. One was on the gender affirming care, and the other one was on the 2023 OHA Ombudsman annual report. And at the culmination of that conversation, OHPB members committed to support these letters, ask our liaisons to follow up with our Health Equity on next steps. At the Equity Committee's April board meeting, committee members asked that OHPB write a letter of support to accompany these two community action letters and share them with OHA leadership, and to both amplify and invigorate, I would say, those letters. So to affirm that and publicly support this important work. So as liaisons to the Health Equity Committee, I'd love to ask Carly and Dr. Hemming to reflect on that a little bit further and even consider drafting for Oregon Health Policy Board's consideration that would basically form the letter that the committee itself is asking for. So before we move through that, Carly, Dr. Hemmings, any reflections from the Health Equity Committee meeting itself, a consideration of this notion of writing the board's amplifying letter, I suppose I'd call it. Yeah, Carly, do you want to go ahead and stop? Yeah.
Yeah, sure. I'll just underscore the gratitude and that the Health Equity Committee had at their April meeting for the conversation we had at our April meeting in support of these letters. We did ask kind of what would be a next step in your perspective that would add value to the statements you've already written, and it was pretty clear that something coming from the board specifically would be value to not only the Health Equity Committee, but to the ask in those letters specifically. So I think, and Dr. Hemmings, I would welcome your thoughts and perspective too, but I think before Dr. Hemmings and I step back and try to draft something for reaction, we'd love any thoughts or kind of perspectives that you would want to see lifted up in our own letter. And I know we looked at this a month or so ago, so you may have to kind of dust off the cobwebs there. I had to. But I think that's the intention before we spend some time drafting something that we get to hear from you first. Dr. Hemmings, would you add anything?
No, nothing to add.
Yeah, any reflections, thoughts, requests before we kind of step back and draft something for next meeting's reaction?
Oh, go ahead, Kristen, please.
I'm excited by this. I really appreciate the leadership from Carly and Dr. Hemmings as liaisons to help this transition from like, yay, we received these letters, and then how does that translate to action? So this is I'm taking a lot of pleasure in seeing our board liaison role really like work in some ways that have been envisioned. So this is beautiful. Also, regarding these letters, I think when I think about a board statement, I'm excited by it. I have two thoughts. One, that and just to say this out loud, because I'm sure you guys will do it, but to honor the voice that the community already put in wording those letters the way they did. And I don't like I would like our letter to not try to rephrase their work and let the community's work still speak, but how are we saying yes, and then how are we further parsing? That letter had things that were appropriate for the board, things that were appropriate for OHA, that OHPB can be like, hey, OHA, are you doing this? And then some bigger picture things. And so maybe our letter can start to parse the more specific role of OHPB in those asks.
Yeah, Kirsten, that sounds right on to me too, you know, and I was thinking about the letters that I'll take the gender affirming care one in particular, and I think the ombudsman also had some features of this, which are some of the elements in those letters have long range timelines, and others are, you know, bodies of work that I believe are currently in place. You know, so there's something about the board's, you know, openness, desire, like strong desire to hold progress over time, and to stay vigilant with our own discipline of staying attentive so that progress is made, you know, and I don't know necessarily that that's something we've necessarily asked the agency to do quite in this sort of a way, at least for the time that I've been on the board. So there's a part around framing that such that the community can see progress, you know, in using this public forum as a way to demonstrate milestones, you know, or demonstrate, you know, the agency's, the leadership's action toward, yeah. So in my mind, there comes this place of finding agreement and kind of movement within it that I want us as a board to stay attentive to. So Carly, I don't know if that's helpful in terms of Dr. Hemmings in terms of framing it, but it's mostly like we've asked the community for their feedback. They've provided feedback. We're listening deeply. Here's what we want to do with what we heard, and to land it, that feels important. Yeah, so frames around that. Carly, what are you thinking, Dr. Hemmings?
Yeah, no, I think that's super helpful. And I really appreciate the points about not rephrasing or, you know, kind of, I don't know, taking the statements out of the context that have already been really well crafted, more around, okay, what is our expectation as a board around what happens next? So I think that's incredibly helpful. Any other thoughts that anyone wants to add? Otherwise, we can take this and draft something, of course, for reaction. I think, Kirsten, thank you for modeling wordsmithing a North Star, and we can do a similar, Dr. Hemmings and I can kind of step back, do a similar activity and bring it back to the full board.
Great. Thank you so much for that. That's really important work. I look forward to the next steps in it, Carly and Dr. Hemmings, very much so. Thank you. Okay. Next up, a few other things in our deck here for this first half hour of board business. Really just a reflection on the committee digest. As you can look at the attachment, it's 1.2 in your packet. There's a great deal of work that our committee leadership and our committee staff put into this particular body of work. And so I personally find a lot of value in reading the committee digest and really reflecting on how each one of the committees intersect with the board and with one another. And so the latest digest, I think, amplified a few of those things that really do speak to the connection among them. So if you haven't yet taken the time to review that, I'll encourage you to do so. In my review, there were a couple of things that I knew that the publishing of the committee digest was a little bit out of date, and mostly that there's some things that we've shifted in the Behavioral Health Committee, for example, at last month's meeting. And that's just from my perspective, a normal process of capturing information and freshening up documents like that. What I do want to propose to us as a group is that we move to a schedule where our liaisons at the board meetings themselves, so all of us who have that role, take a little bit more of an active role in providing live updates to the full board about the committee work itself. So we've got the written digest as a way to anchor ourselves for all of the committee work that's happening month by month. And yet every once in a while, it's really helpful to highlight, I think, the committee's work and to do so in this public forum and have the liaisons speak to what they're exploring within the committee. So this is my intention for bringing it up in this way today is mostly to give us all a bit of time to reflect on that idea. And if it's something that you support, then what I imagine we'll do is start to calendar the committee reports out through the rest of the year and into 2025 so that people have time to prepare, talk with the committee staff as liaisons and identify what are the things that we really want to amplify for this public forum and also for other board members to be thinking about as they're doing their liaison work with other committees. So with all of that, what reactions do you have if I sign you up as a committee liaison to introduce your committee and speak to the committee's work? What information and support would make that possible for you? Yeah. How about bad reactions? Bad idea, Brenda. Don't like it at all. Anything there? Yeah, please, Carly.
I think it's a great idea, and with enough notice, acknowledging the calendar and when we're meant to kind of share high level takeaways or activities that each committee is working on, it gives us ample time to be thinking about that throughout the months. So I think it's a wonderful idea, Brenda.
Okay, thanks, Carly. Thanks. Any other reactions or preparation support that you'd need in order to do this in a way that feels right by you? Yeah, please, Bill.
I think it's a good idea too. And I agree with what Carly just said. Okay.
Ample notice and support, and then, okay. And my experiences are committee staff are so just remarkable, and do so much of the heavy lifting for us. So there's a piece of it that I think, we can count on their wisdom and expertise to make that process a little bit easier as well. So, yeah. Okay. So we'll move forward with that intention. I'll work with Kirsten and Tara and the team to plot out those committee report outs through the rest of 2024, and we'll just give it a shot. If it doesn't work or you want to do something different, of course, we can modify this as we move forward. So thanks for your willingness to engage it that way. So before we move off, I think I've got one more minute or so. There's some reflections on the committee reports or anything in the digest itself you have questions about. Just give a little room for that. Looking at your faces. Yeah, please, Bill, go ahead.
Since we just have 1 minute before the next agenda item, just wanted to ask a question about the attachment 1.3 summary of the healthcare market oversight program. Appreciate this information, but it seemed conspicuous in its absence was one transaction which has been very controversial and has had a lot of public comment on, which was Optum's acquisition of the Corvallis Clinic. I understand that the process for that was modified, so that enabled the transaction to go ahead. It seemed to me that something about that should be reflected in this report. Don't need to ask for a response right now from Sarah or Arlen or anyone else at OHA right now. I just ask for that to be included in future reports.
Oh, thank you, Bill. My reflection, I think there's a really pointed request that you're asking, which will be, let's see if I get this right. Not only are we looking at current transactions that are under review, we also want a little bit of visibility on the ones that have transpired. And that may be kind of a second addendum, or it might be something that in our packet, gives us a little bit of visibility to the ones that have been completed under the program's review. I think that's a reasonable request, Bill. I know that specific item that you just referenced was in last month's meeting packet, and we can make sure that we have an ongoing kind of trail to look at the program overall. Bill, does that accomplish what you're looking for?
Yes, of course, it's subject, there's a much broader issue here too.
Right.
That will need to be addressed, but I think at a minimum, to have for a transaction like this, to report out what the conclusion of at least the initial investigation and what the conclusion of the process was. Thank you.
Right. Thanks, Phil. Yeah, Kirsten, go ahead.
I'm gonna get real weedy here, but just so these are the transactions currently under review. There's transactions that have gone under review, and then where Optum would fall would be transactions that, I mean, they did not get reviewed in the end, right? Like got an exclusion from the program. And if I recall correctly, I think some of those emergency exemptions like are public and some can actually happen not without live reporting. There's space for that when there's concern about public, I don't know, when it may not be in the public good, as I recall. And so anyway, I think it'd be helpful maybe staff think about how this gets parsed, but just to be super clear, like we're asking for transparency. There's a kind of a middle area that we're asking for transparency there. So maybe, yeah. And Sarah, I see you come on camera if you want to be put on the spot, great. If not,
Actually,
pressure.
What I'd like to do, and I recognize we may have time later on the agenda, I want to be respectful of the next item and time too. So Kirsten and Bill, I want to hold this for now and make sure that if we don't cover it today, that we do so in our leadership meeting and we bring back to next month's board meeting a line item kind of around where this conversation moves in the interim. So with that, is that all right, Bill? Yeah, go ahead.
That's fine.
Okay, perfect. Thank you for the question. That's really great. All right, next up, I want to welcome Dr. Sejal Hathi, our Oregon Health Authority Director, for some updates. I know we've asked for a few updates on recruitment, strategic plan. Dr. Hathi, the floor is yours. I'm looking across my screen and I don't hear you yet, Sejal. I don't see you yet either. Tara is.
She's there. It just looks like she's
can
getting ready to unmute.
Yeah.
Oh, perfect. Okay, thanks. Sorry.
Can you hear me now?
Yes, thank you and welcome.
Awesome. I cannot see myself, but I did want to own that I am in an OHSU lobby. I just finished a doctor's appointment for myself. And so I am logging on using the Wi-Fi, and there may be a bunch of background noise. So apologies for that. So I think you were hoping to hear from me a couple updates today, one related to the strategic plan, and secondly, related to executive recruitment. So I'll take the strategic plan first. On that front, I think I shared in March that we are in full swing crafting this deliverable that the governor expected by June 1st. We've identified 5 goals, each of which encompasses a body of work that we are already undertaking and that translates that 2032 cross-divisional programs and policies. And so those 5 goals are: 1, strengthening access to affordable care for all, and we have various strategies and actions outlined underneath those. 2, transforming behavioral health. 3, fostering healthy families and environments. 4, building our own internal capacity and commitment to eliminating health inequity. And 5, a tribal goal that's in the process of being developed with the 9 federally recognized tribes in Oregon for our tribal consultation policy. What we've done thus far is, for each of those 5 goal areas, developed additional 5 strategies and 3 actions per strategies, as well as metrics or monitoring and evaluation plans that we'll be using to hold ourselves accountable Our sponsor team is now in the process of reviewing the last piece of that, the monitoring and evaluation plans, and we're working with a contractor to translate a considerable body of work, hundreds of pages, into a pithy and clear strategic plan that we can both share with the governor and disseminate publicly. I am also encouraging my team to think intentionally about a broader societal call to action. And what I mean by that, as I've talked about, I think in a few other settings, is mobilizing a coalition of actors across their ecosystem, from payers to providers to civil society and academia, as well as our other counterparts in state government, to think intentionally and deliberately about what commitments they too may be able to marshal toward achieving our 2030 goal across any of the 5 dimensions that I outlined and that we elaborate in our plan. And I'm advocating this approach because I don't think as a singular agency, we can ourselves eliminate health inequity. We're going to need to have all partners at the table rowing alongside us, and it can serve that convening role, that mobilizing role, because we're the first to have articulated and centered this goal, but we need to do it in partnership with others. And so I'm hopeful that we can continue that conversation with the board as we get closer to this summer. So that's my update on the strategic plan. I want to share a couple additional updates. By the way, please let me know if you can't at any point hear me, but I want to share a couple additional updates about OHA recruitment. So as I shared, I think in a prior meeting, we have multiple executive recruitments occurring simultaneously. Also, as alluded to in a prior meeting, our HPA director search unfortunately had a failed recruitment, but we have hired an executive search firm, Spirit Consulting, to drive the recruitment process for us. And they are leading a national recruitment process, both for the HPA director and for the Oregon State Hospital superintendent, with the goal to find at least 5 candidates for interview for each of those positions in the next month. The Medicaid director role is at the final interview stage. Thank you, Kirsten, for joining one of our interview panels. I plan to make a selection in the next week based on the feedback that we've received from all of those panels across all 3 of those final candidates. And I'm excited. The agency. For our CFO or Chief Financial Officer, we are initiating interviews this week and hoping to get a set of final candidates and ideally an offer by the end of May. Similarly, for our CMO or Chief Medical Officer, we are doing initial scoring. We received many more applications than we anticipated. And so we are wading through those right now and scoring them with a plan to conduct interviews in the next couple of weeks. Dental director interviews are also underway. There are 9 interviews that are happening for that role, and we're hoping to narrow those down and select someone sometime this month. And then for the public health director, we have initiated the second round of interviews with the goal to get to final interviews also in the next few weeks. So progress is being made across all of those positions. And I am hopeful, based on that we'll have folks at least selected, identified, and initiating onboarding by early summer. A lot of the candidates are also outside of Oregon, and so the actual start date will depend on when they can move their families, and we'll obviously be giving them grace for that too. So happy to take any questions on either of those topics. And then just as a last quick note, I will share that I am approaching the final 2 regional visits for our statewide listening tour in Hood River and in Eastern Oregon next week and 2 weeks following that. And it's been a really, I think, healthy and instructive series of conversations that I've been having over the last few months. We have been hearing a lot of really valuable input and ideas, and are hoping to release an informal report this summer as I mark my 6th month, outlining what we learned and a few of the actions that we're taking responsive to that feedback. So that's my update. And again, can't see myself and don't know how I sound. So apologies for all of the probably commotion in the background.
Actually, you've done quite well, Dr. Hoppy. It's you came across loud.
Oh, great. Okay.
Yeah, thank you so much for that. I'll just turn it and open to board members for questions or reflections on anything Dr. Hoppy has shared so far. Questions that you may have. It's a quiet crew so far this morning, Sejal. Oh, there's Kirsten. Go ahead.
I wouldn't leave you hanging, Brenda. Thank you so much for that update, Sejal. I'm really excited to hear about the strategic plan and appreciate the specificity of both laying out the goals, action items, and kind of accountability tools that are really thoughtfully being built into it. So great job on that, and to all the people working on that and who will help execute that. So you said plan due to the governor by June on June 1st. Will you be discussing that at well, might be the July board meeting for us then?
Yeah, I think we can certainly aim to do that. I don't see any reason why we wouldn't be able to do that. So July board meeting sounds great. And I think the way the process works is we will be submitting it to staff on June 1st. Staff will be reviewing, making sure that we have everything in place, nothing is missing, nothing needs to be further evolved or edited. And then at that point, DAS will send it, pending any iterations that may be necessary and appropriate, to the governor's office for review, after which it will be posted publicly. So that's my understanding of that process in June.
Thank you for that. Thank you. Other board members, other questions? Carly, go ahead.
Thank you, Dr. Hoppy, for your update. Really appreciate hearing both the hiring space, which I imagine is consuming more energy than you'd love, and the strategic plan update as well. I'm curious, and it may be too early for this, but I'm curious if you are seeing any areas or if you're having any preliminary thoughts around the board's role in helping move the strategic plan forward once it's finalized.
Yeah, really excellent question, Carly, and I'd love to continue that conversation and hear from the board itself how you think given all the other directives and requests from the governor, where you think you can best support. But I would say on that call to action and on what we are calling track 2, and I think Christine shared a little bit of that when she presented at the board back in March, but that community engagement framework that we will be rolling out as part of the next phase of the strategic plan on those 2 fronts, both of which concern, I think, again, building partnerships, mobilizing a coalition, engaging community. I think we could really use the board's expertise and support, given that you've led that type of work in so many other instances over the last several years. And then I would say, I mean, our strategic plan is and it is broad, and it's going to take relentless focus and persistence, not only over the next several months, but over the next 3 and 6 years. And so working with you to problem solve any challenges as we approach the next budget, which will constrain some of our vision there. And as we work to monitor progress, I just having you as a sounding board would also be, of course, helpful.
Thank you. Dr. Hockey, I wonder if you can speak just for a moment. I'm so impressed by the community roadshow effort. And I know you said you'll be culminating all of what you've heard and sharing out with communities around what that means for the agency, what it means for you and personally and the teams that you work with. Is there anything that you feel comfortable sharing with us at this stage of what you've heard thus far, or the themes community by community that are important for this board or for us just to keep in mind as we do our work?
Yeah, so I've heard a number of themes. I would say probably the three that have recurred most consistently have been, first and foremost, workforce shortages. And these are shortages that are blighting and challenging not just local public and mental health departments themselves, but also more broadly our behavioral health workforce, our primary care workforce. I think communities and counties really across the state are struggling to recruit and to retain, sometimes in spite of the resources, the scholarships, the loan repayments, the additional the increments in Medicaid reimbursements that the state has provided them. I've also heard about the unintended consequences of some of those policies, especially on the behavioral health side, which perhaps have reduced or compromised parity between public and private practice providers in a way that we did not anticipate. So I would say just workforce broadly is one bucket I've heard about consistently. Secondly, I think the importance of geographic inequities, or of acknowledging and addressing geographic inequities as we work to advance health equity, especially in my visits to rural and coastal communities. I have heard repeatedly that those communities feel excluded, unseen, and undervalued by our programs, by our policy, by something as basic as our funding formulas. And I think we need to do a better job of also responding to their concerns and making sure that we are caring for and resourcing rural health as well. And then thirdly, I've heard a number of ideas about CCO procurement, and far beyond me at this stage to some of those desires and suggestions. But I think that the next procurement could present a compelling opportunity to better bridge our public health and healthcare systems, to invest more in prevention, and to more directly respond to our growing behavioral health crisis. And I've heard a number of suggestions for how we could do all three of those things better.
Thank you so much. That's really helpful. Got one more question in my mind. I'm looking to the group first to see if anyone else wants to jump in before we. Okay. I'm just thinking, just as an organizational leader, what it must be like to recruit and onboard an entirely, not completely 100% new, but a leadership team at a time of such significant transitions within the agency. And so just a preview into how you're thinking about creating the kind of culture and synergies among a new people as you onboard through the rest of 2024 and 25, not only as they get accustomed to their new roles, but how you're thinking about the dynamics of the team that you're aiming to put together. Anything that you feel comfortable sharing?
Thanks, Brenda. I would say that's probably, of all the intractable policy challenges we're facing, culture building and team building, especially with so many new faces coming in, is likely the biggest challenge that we face. And I would say I want every member of the leadership team to feel like they have each other's backs and we're in this together. And I'm not sure that we're there right now. And so building trust among that team, building a sense of belonging and ownership in our mission and our vision, camaraderie, a culture where if you don't talk about people, you talk to people. I think it's really important to me. And I am hopeful that because we will be bringing so many new individuals that may not have the local trauma of serving here over the last several years, that will become perhaps an easier lift. We'll see. But I think that team building is obviously incredibly important. We are doing our very first leadership team retreat in a week, actually, next Wednesday, to begin to invest in some of that trust building. But it's going to take continued focus and norm setting, where a lot of that perhaps maybe fell by the wayside during the pandemic.
Thank you. Thank you so much. Let us know if we can do anything to support you in that. We know it's a big lift, and happy to help along the way. Yeah. All right.
Thanks, Brenda. I would just say one more thing, and that is, I think it's really important to me to lead with a coaching perspective rather than a judgment-driven perspective. And I fear and have observed that the latter is perhaps where some feel more comfortable. And I would welcome the board's input about how to cultivate a more trusting, coaching, restorative, justice-oriented approach rather than a punitive, belittling, judgment-oriented approach. Because I think the former is how we build trust, and the latter is how we splinter it. And so any ideas from the range of leaders on this team for how to do that effectively, I would welcome at any point offline at a next meeting. Appreciate it.
Oh, thank you so much. That's a beautiful request. And I know personally I'm taking notes, and we'll happy to share some thoughts with you. And I suspect, as I'm looking at head nods on the screen, that there are others who are nodding as well. Thank you so much, Sejal, for that. With that, also appreciate that you're taking time away from your personal appointment to join us all today. That's pretty impressive. Thanks for hanging in with us, and have a good rest of your day.
Take care.
Thank you. Okay, next up, I am honored to welcome the Healthcare Workforce Committee and leadership who have come to share with us a body of work that they've been diligently doing for quite some time. It's a nice segue from Dr. Hathi's comment about community listening around the impacts of workforce. And what I'd like to say by way of introduction is that there are many leaders inside our Healthcare Workforce Committee that dedicate a lot of their time, energy, and focus in community to help address the workforce challenges that we have. And we're really lucky to have them doing this heavy lifting for the state. So with that, Melina and I are both liaisons to the specific committee, and welcome Laura McKean, who just came off camera or on camera, who is the Healthcare Workforce Committee Chair. I believe Aaron Strauss may also be here, who's our Vice Chair, and certainly welcome Neelam Gupta, who is our Oregon Health Authority Director of Clinical Supports, Integration and Workforce Unit, if I got her title accurate. Hopefully I did it justice. So they've all joined us today to help us understand the member review or sort of our committee composition, and most importantly, an updated charter that is in your packet, and the link is item 3.1. So with that, Melina, anything you want to say by way of welcoming this team to our conversation today?
Just welcome, and I appreciate your hard work on this charter, and yeah, look forward to working with you.
Great, thank you. So with that, I'm not sure who's actually going to start us off, Laura, if that's you, or if Neelam's going to kick us off. Either way, the floor is yours.
Okay, thank you so much. Neelam, are you okay if I take it away? Okay, perfect. And Tara, could you bring up our slides that we have? Thank you. So as Brenda said, first of all, thank you very much for having us here this morning, members of the Oregon Health Policy Board. We are excited to present this charter. Like Brenda said, it was in your packet, so you could review it. We're just going to go over a few key points this morning. Again, my name is Laura McKean. I am the Senior Director of Oral Health Services and Community Engagement for All Care. And I actually should have termed out last year for chair, but we didn't really have anyone that wanted to step into the chair role. So Brenda twisted my arm a little bit. She didn't really. I'm happy to serve one more year. However, I do have a very competent vice chair who is excited to step into the role next year, because 3 years is enough being chair, and it's time for him to take over. I will remain on the committee as immediate past chair, so I can support him. But thank you for being here. If you could go to the next slide, Tara. So just kind of a brief overview. This charter hadn't been looked at or revised since 2019. So we decided we need to work on it. Brought up the Health Equity Committee Charter that you all approved in 2023. We formed a committee to look at this charter, worked pretty hard on it. We did bring it back to the committee, and there were a few changes that need to be made. So the subgroup got back together, decided to make those changes. We did send it to Brenda and Melina, who gave us some excellent input on a couple of items in the charter. But it does expand some components, which is nice. Areas of health equity, the strategic framework that the committee developed, committee support. And let's see, next slide, Tara. And Neelam and Ian, feel free to jump in anytime. So this charter is pretty long. I had a little bit of anxiety about how long it was, because I've not had a charter that's this many pages before. So that gave me a little anxiety, but it's got such good information in it. So I had to put that aside. But we do talk about the authority of the committee organizational location and relationship. We do really try to get a diverse committee group together. We always have a little bit of difficulty in sometimes the Eastern Oregon Coast Range. However, we did succeed in getting a couple of folks. I think Christian is from John Day, which is about as remote as you can get in Eastern Oregon, besides Heppner. So we did luck out there. We wanted to make sure that we included the health equity definition. Like Brenda, we recite that at every meeting, although I think I might take your charge, Brenda, and pass that around to the committee members every month. I think it's good if they recite that and not just have the chair recite it. And that's really important to me, that we make sure that we recite that every single meeting. We wanted to include, of course, the tribal sovereignty and the health equity statement as well, and the health equity framing guiding questions. Next slide, Tara. Okay, so section 2 is our strategic framework, the vision and mission of the committee. We talk about the scope and deliverables, the review and reporting and evaluation. We do conduct some aspects of every 2 years. We needed to add some structural process and workforce systems, as well as outcome measures. And that really came across pretty loudly with the committee. We definitely wanted to have some data sources that would prove to be effective, and outcome measures. So next slide, Tara. Okay, committee membership, organization. I touched on this a little bit. We did need to talk about the composition, recruitment, appointment, term lengths. The one thing that came to mind for me when we were talking about recruitment is the application for the Healthcare Workforce Committee. I filled out the application myself and it was really tedious. So I'm thinking that we might take a look at that application. We'll of course keep the required elements in there, but I think we talk about all the time a 6th grade reading level in our documents that OHA approves for us as a CCO. But I think we need to take a look at this application and see if there's a way that we can make it more user-friendly, because I felt it was really complicated. So I'm going to look at that too. Removal replacements. If a committee member decides to resign, how are we going to handle replacing that committee member? Because we want to make sure that we have a good, robust number of committee members. I talked about House Bill 2992, which is the compensation bill that passed for committee members, to make sure that, whoever is participating and is eligible for that stipend for the committee can receive it. Committee organization, of course, committee officers and duties, standing and ad hoc work groups. I'll have to check, Neelam. I don't remember specifically if we addressed the timeline for chairs. I thought we might have a little language in there to cover like what happened this year where we didn't have somebody that wanted to step in and be chair. And so I volunteered just to do it one more year. And I don't remember if we addressed that. For some reason, I'm thinking that we did. But again, happy to help out for this year. And committee support, the OHPB liaisons, which we're so fortunate to have Brenda and Melina as our liaisons. We have I guess we could call it a leadership meeting once a month with Melina and Brenda to talk about the meeting that's going to happen the following month and what support we might need from them. So Brenda and Melina, again, thank you for being such great liaisons to our work group. And next slide. Committee operations. We do, as a formal committee, we are required to meet every other month. We have started, I started this a couple years ago when I first became chair, to maybe have meetings in the off month, maybe some educational webinars like the OHPB does sometimes, because we have 3 hours for our meeting. And sometimes that's just a lot of information to pack in 3 hours, and we don't really absorb the information. So we sometimes will have meetings in the off months. I think we are every off month this year, we're going to do something in our off months. And that way the committee can get together in the off months and ask questions, get clarification. If we do have a topic that we're going to discuss, it's much easier to do it in the off month. Because like I said, we pack so much information in that 3 hours that it's difficult to absorb it all. And by the end of the 3 hours, you're just like, okay, what did we hear? It just went by so fast. So I want to make sure that the voices are heard in that committee and that we have enough time. Let's see, decision making and voting, that's in the charter, committee communications, media, lobbyists, and then any amendments that will need to be addressed and how that will take place. And next slide. And then we have our, of course, we have our definitions and acronyms, and we always try, we're pretty good about spelling out the acronyms in the chat if we need to, or calling them out, which is nice. And next slide, Tara. Okay, discussion. And before I go into discussion, I want to ask Neelam and Ian if you have anything to add to this discussion, and then we'll open it up to questions from the board.
That was great, Laura. Thank you. No, I think you really covered the document. Happy to answer questions.
Yeah, no, thank you so much, Laura. I would just only add one thing around the strategic framework that the committee developed. It was building on the 2023 Healthcare Workforce Needs Assessment. The committee went through a process where it prioritized the recommendations and grouped them into 3 areas of workforce diversity, workforce wellness and resiliency, and workforce development and retention. And we also, the committee then formed work groups that develop strategy papers, which are also linked and included in the charter.
Thank you, Neelam. Okay, I will open it up to board members. Do you have any comments, questions, discussion for us?
Dr. Hemmings, go ahead.
Yes, hello. Thank you, Laura. I appreciated the charter, and even more appreciative to hear your comment regarding really taking a look at the application. Because I think, that could also be a barrier to people who are interested in applying. And I think that goes for all of these committees. I'm often struck by the makeup of committees at times. And I think the application, the questions and the framing of the applications, I think lends to how committees are made up, and sometimes may end up excluding people with lived experiences, who may not necessarily be in leadership roles in organizations. So I think there's some equity issues there. So I just wanted to say to you, thank you for, addressing that and really taking a look at it. I was also very pleased to see that traditional health workers was being called out. And I forgot who it was that had pointed that out, that was needed to be done. And I was happy to see in the final draft version that the board is going to vote on today that was called out and included, because I think, with everything that's going on in the state today, traditional health workers play a crucial role in addressing some of those issues, and I think needs to be highlighted as to the importance of the work and work that they do. And I think that's my only comment. Thank you.
Thank you, Dr. Hemmings. I always appreciate your comments. I was telling someone, I love Dr. Hemmings because she keeps me in check. So I appreciate that. And I do agree with you about the application. And that's why I kind of wanted it addressed, because it was pretty non-user friendly.
Thank you.
Thank you, Laura. Thanks, Dr. Hemmings. Tony, go ahead.
Yeah, thank you again for the presentation. I was digging a little bit more in the weeds, and I remember going back when the presentation, I forget when it was, but on the measurables and reporting. And I was curious, I think the measures as far as workforce system, retention, but I was curious, it looks like we're focusing on a number of specific areas, but just the thought of thinking about the number of training programs in respective fields, and if that's something that gets put in the reporting, and what we're ensuring that we're having adequate training centers and across the multidisciplinary approach that we're thinking about team-based healthcare. And I just didn't see it listed under section 8 And if that's something for us to pay attention to, more of a question. In thinking we have, I just think of like our nursing staff, and I know we have those listed, but in primary care nursing, there's a lot of challenges to get that. There's a lot of challenges as far as the locations for medical assistants to be trained. There's really challenging settings for our behavioral health colleagues to get the training subsequently from where they need 3 years of observation and a support structure for that, right? And I'm just curious if we're identifying in being analytical with those. So just more a question and forethought as we're continuing to refine where we're looking for that data.
Thank you, Tony. Neelam or Laura, do either of you want to respond to that? I think really thoughtful addition to the committee's scope of work and where we focus on the capacity side, of the workforce picture. Neelam, go ahead.
Yeah, thank you so much for that really thoughtful comment. We do work with colleagues from the Higher Education Coordinating Commission. We serve both on the statewide Workforce Talent Development Board. We have an ex officio appointment that's been longstanding to that group, as well as the Future Ready Oregon large investment that was made 2 years ago. They stood up a healthcare industry consortium, and we also serve on that group as well. And we'd be happy to bring this to our colleagues on that group. I know that they are doing some industry focus groups right now, and we're hoping to include some of that information in our upcoming healthcare workforce needs assessment. So that is a really great call out and point. And I know that some of the investments that were made in previous legislative sessions are also addressing that. I think in particular to your point about limited nursing clinical or limited nursing educational slots. There are some community colleges that are planning to start bachelor's programs in nursing.
Thanks, Neelam. I appreciate that. Yeah, I just think identification of like, where's the total number of training spots? And there are means by which we can augment or, look at that in a different way and thinking of, we had conversations of looking earlier on in training. I think it would just be helpful information. So thank you.
And I think, oh, go ahead, Melina, I'm sorry.
Oh, go ahead. If you had a comment back to Dr. Germain, go ahead.
Okay, thanks. I was just going to say we're also, that's a really good point, and it reminded me down in Southern Oregon, our community college, Road Community College is looking up, they're applying to be a dental hygiene program down there. They're looking to get their CODA accreditation for that. So that'll give us one more dental hygiene school because we're just so short. And the other thing I just wanted to mention is we had this in the draft charter and we changed it. It said, it really, the words were provider, healthcare provider. And so we thought it was really important to say healthcare professional because there's a healthcare professional is a more broad term that encompassed what we felt the healthcare profession was and not just a healthcare provider. But yes, that's a really good point. And I might just kind of take that on to get a list of exactly what we do have in the state.
Yeah, thank you for that, Laura. And that may be a space where our liaisons can be supportive as well to be thinking about what the follow-up looks like to this question.
That'd be great.
On capacity. Thanks, Laura. Ian, did you have a reflection on this topic before I move to Melina, or?
Just to state that a great question and something we saw when we were looking at the strategy papers, which I believe were presented to this group, in workforce wellness and retention, we looked at pathways programs as one of our key areas for the healthcare workforce to look at. And so just to say that I agree with you, and I see that as part of our mandate and our conversation moving forward in HCWF. So thank you.
Thank you, Ian. Okay, Melina, what you got?
All right. Well, first, I just want to thank the committee for this body of work. And like you said, it wasn't looked at since 2019, I think you said, Laura. So I appreciate the update. I appreciate the clear mission of diversity, wellness, and retention with clear deliverables in the reports and the reevaluation every 2 years with the goal of health equity. I did challenge the committee to, in the reports, to dive deeper into the race and ethnicity of the workforce and look at that in the report. But I just wanted to say thank you again, and I fully support this charter and look forward for the board's approval.
Thank you, Melina.
Thank you, Melina. Any other questions for the workforce committee group? Reflections. I'll just double down and echo this incredible body of work. I mean, it is, I know that this committee, looked at other charters for board committees. The Health Equity Committee, I think, was first, and now I'm looking at how comprehensive this review is. And of course, my structure brain wants to think about our other committees of the board and, how much we can standardize across both the application process, to Dr. Hemming's point, as well as the mechanisms that are really clearly articulated in this charter. So just know that it may have a shelf life that is a stronger and bigger platform and duration, perhaps, for us to consider as a board. So thank you for it. With that, Melina, I'm curious because it sounded almost like you were moving approval for this charter. Didn't it feel like that? Yeah.
Yes, so I would like to put a motion forward to approve this charter.
Thank you. Is there a second?
Second.
Thank you, Dr. Hemmings. It's been moved and seconded. Any other remaining questions for the group? Hearing none, all those in favor, please signify by saying aye.
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 Any opposed? Any abstentions? I think we caught it all. Great, motion carries. Thank you so much again to our committee leadership and all the committee members who contributed and staff to this body of work. It's extraordinary, so thank you.
Thank you, Brenda. And again, thank you, committee members, for letting us come and share today. It's been really one of the most positive things in my job to be able to be a part of this work. So thank you. And I don't know if Neelam, if you and Ian have any parting thoughts.
No, I would just echo thanks, and particular thanks to to Laura and Ian for leading this work, and the work group that really spent a lot of time on taking the really great charter that the Health Equity Committee created, and then making it the Healthcare Workforce Committees.
I'd also like to echo the thanks to all, and also especially to Brenda and Melina, who gave some really thoughtful feedback to the document and gave us a chance to look at things from a slightly different perspective than we've been bringing originally. So thank you.
Great, thank you so much. Okay, I do see someone else's hand raised on the call. Andy, did you intend to do that?
Brenda, no, I apologize. That was
No
a mistake.
worries.
Thank you.
Yeah, thanks, no worries. Okay, so with that, I'm going to move us with a little bit earlier notice to our break. What I'd like to do as we come back from break is pick up the conversation that Bill and Kirsten were having about kind of a follow through on the HCMO reporting process. So I know that Sarah Bartleman gets to join us just coincidentally to talk about the healthcare cost growth target program, but I'd love to wrap up that conversation that I inadvertently cut short. And we'll pick that up after break. So let's go ahead and stop now. We'll take 10 minutes and we'll set the timer. Go ahead and refresh and break, and we'll see you all back in 10. Thank you. All right, welcoming back our board members and community for second part of our meeting today. Our board members could turn your cameras back on, that'll let me know that you're here. Maybe a few more minutes to warm up. Perfect. Okay. Great meeting. Thank you so much for your attention. Hopefully you had a nice break there. We will now pick up with the next item on our agenda is public comment. And I got a note from Tara that it looks like we don't have anyone who has signed up for public comment at this moment. So I'll just give a few moments to see if anyone else has joined the call and would like to sign up for public comment that hasn't yet submitted their interest to Tara. A few moments to see if anyone would like to share. Okay. You can always adjust at the end of our meeting if indeed someone does come. So thank you, Tara, for tracking for that with us. Hearing none, we'll go ahead and pick up the conversation that I mentioned right before the break and invite Sarah Bartleman to join us to give a little bit more insight on the documents for HCMO reporting. Anything, I don't know if you were here and present for this, or, oh good, earlier conversation, so you've got the background, no need for me to repeat that then. So Sarah, I'll turn the floor over to you if there's anything to help us understand the process a little bit differently. And then we'll move on to you and Bill for the presentation on the healthcare cost growth target program. So Sarah, go ahead.
Great, thanks. Good morning, everybody. Sarah Bartleman, she, her pronouns. I manage the healthcare market oversight program and the cost growth target program for OHA. And I think what might be most helpful for the market oversight information is to talk a little bit about the update that we're providing to you each month, and then talk about our process for review and follow-up. So on the process for review and follow-up, just making sure that everyone knows that for every transaction that we review and then issue a determination on, we are statutorily required to do a 1, 2, and 5-year follow-up review. So we are now just starting to roll through that. We've existed long enough as a program to start to be starting to come up on those 1-year follow-up reviews. We published our first follow-up review last month, a couple of weeks ago, involving the SDB transaction. And you'll see several more coming out over the next couple of months as we roll through. So those follow-up reviews are an opportunity for us to look at what has happened since the transaction has closed. If the entity made commitments in the notice or as part of the terms or other conversations that were happening, we'll follow up on those. We are often requiring entities to report back to us as a condition, one of the conditions in conditional approval, so that we have some data or some information that's provided more qualitatively to help inform those follow-up reviews. So for example, we might ask, did policies change after new ownership has come in, and what does that look like? So those follow-up reviews will continue. You'll start seeing them more and more as our program continues to exist. And I think I'm hopeful that that will address a lot of the earlier conversation you were having about like what happens. And these are really an opportunity for us to say we had these concerns, or the community raised these concerns in public comment when we did the review in the first place. Now let's look back and see what has happened. We also open public comment periods as part of the follow-up reviews, and we'll accept and incorporate public comment as part of that as well. So all of this information is also on our website, and Tara just added the link so you can sort of track through and follow along. In the monthly updates that we are providing to you, we will also flag when a follow-up review is completed so that you can see that. In terms of that monthly update, I did have a conversation with, I want to say Brenda, a couple of weeks back about if there was anything that we could do that would make those updates more helpful for the board. So I think that's still a bit of an open question. There were some examples of other programs that also provide written updates to the board and how we might be able to model after some of the information that they provide. And so I think that's an open conversation. If board members have additional thoughts or requests about what would be helpful or how we could modify that written update, I think we're really open to that, and we'll see how that evolves over time. And I'll stop there and see if anyone has comments or questions.
Thanks very much, Jen. That's very, very helpful, and appreciate all the great work you and the team do on these very complex transactions and sometimes very controversial transactions. It's one thing I think that would be helpful, and maybe was underlying the question that I asked earlier, was I think it would be helpful to know when there are follow-up reviews in process, not just when a follow-up review has been completed. Since there is a public comment process as part of the that follow-up review, having both the board members and the public who's attending these meetings aware of those. I know you do it through other channels as well, but to have that as part of a routine reporting, what are they follow-up reviews that are currently underway? That would be helpful.
Feedback.
So, and so just to clarify, for the Optum and Corvallis Clinic transaction that was approved under the emergency exemption, will there be a follow-up review conducted for that transaction, and when will that be happening?
Trick question. So Optum to Corvallis Clinic, that was an emergency exemption. So that transaction was exempted from the HCMA review process entirely, including the follow-up reviews. The way our current statute and direction is written, if exempt, a transaction is not subject to follow-up reviews. That said, we are reviewing other transactions that involve Optum and United Health, and we're very interested at looking at what happens when Optum comes into a community in Oregon. And so I think we're including some of that information in some of our other reviews. And I think we also have some open conversations that we're exploring about how might we follow up on this situation, this transaction in particular, maybe as part of our state of consolidation work, maybe in partnership with some researchers. We're really interested in continuing to understand what's happening and the impacts. We've certainly heard from the community that there are many concerns, and we hear that, but it will not be a formal follow-up review under the HCMA process because this transaction was exempt.
So just make sure I understand clearly, the legislation explicitly exempts under the emergency clause, not only the initial review and any comprehensive review, but also any kind of follow-up review, and prohibits OHA from conducting any kind of follow-up review for transactions that proceed under the emergency exemption. Is that correct?
That's not how I would state it. And I don't want to get into a legal interpretation sort of live. That's a little challenging for me to do on the spot.
Okay.
But we are not conducting follow-up reviews for exempt transactions.
Because the legislation says you should not.
I would not read that as expressly prohibits, but I also don't want to give you a live interpretation. So if you want to follow up offline with the actual question, I'm happy to do that.
Okay. If I just want to make sure, it seems to me from a policy perspective, and I was not around when the legislation was written, so I'm not familiar with the details of it, either the language or the legislative intent, but it seems to me that transactions that do proceed under an emergency exemption ought to have a follow-up review, just like any other major transaction. And maybe there's some criteria about which kinds or what should be the criteria that or what should be the basis for the review. But if that requires a legislative fix, that would be fine. Or if it's a policy fix, it could be done with OHA. Happy to talk. I'll just state from my perspective, a follow-up review for this transaction and similar transactions is warranted, even though it was proceeded under the emergency exemption.
Yeah, I think we've had and are having a number of similar conversations with legislators asking really similar questions.
Okay, great. Sarah, I know it's sensitive stuff. I know it's legal fraught. I appreciate your handling of this back and forth, but also that as I said earlier, the work you're doing on all these transactions. It's very important.
Bill. We really appreciate the board's support on this.
Yeah, thank you for that question, Bill. And before I move to Kirsten, I'll just, suggest for the board that there are many mechanisms we could probably exercise to understand the impact of community needs, specifically from the access to care or sort of network adequacy kinds of space that would fall outside of the healthcare market oversight program. So while this particular program may have flagged some areas of concern, I think that we might get creative, and I'll take this offline, but get creative about how else we might wonder what's happening in community, and then to ask ourselves and others where we think that are most concerning from the board's priority perspectives of health equity in particular. Bill, just, I just note to self that there's some other pathway we may want to explore, and we can take that independent of the specific transactions themselves. So thanks for that. Kristen, to you next, and then Tony.
Yeah, actually my comment dovetails really nicely with what you just said, Brenda, and I just wanted to confirm, Sarah, something I thought that I heard you say, which is also under the HCMO program. There's specific reviews to transactions, but there's also a collective review of what is happening in the Oregon market. And I think it's under that collective review that it is a big picture of the state of the market, whether it was a reviewed HCMO transaction or not. And I think that I'm really looking forward to that review, the first one coming out of HCMO, and I think that is a space that is that I hope that comes to the board, because I think that big picture trend review of what is the state of our market, where are we presented challenges and holes, and bringing in that community voice that might think about, or what I recall is the intent of that part of the legislation was that individual transactions might they have certain impacts, but there can also be collective impacts on communities that we aren't able to see or feel until time has passed, and there's been many of them or something, and so but that those deserve a voice and perspective too. And so I look forward to that big picture review and board thinking, adding its voice to the many voices of what does this mean and what should be done when we look at.
Thanks for that, Kristen. I think so context, we are statutorily required to conduct and produce a report on the state of consolidation in Oregon every 4 years. So the first report is due in 2026, and likely at some point between now and then, we will want to come back to the board. I think this could be an opportunity for the board to help inform what questions we ask in that review, or what you would think would be important to see. I think because it is very open-ended, this is possibly a great space to incorporate some of the board feedback. And so we can talk offline about when that conversation happens and how we do that. We have a really long list of ideas as a team about what we could do in that report. And we will continue to add to it over time, but the first report is due in 2026.
Thank you for that, Sarah. Yeah, I think I can speak on behalf of the board to suggest that we are probably a eager audience for your early thinking on draft questions for that report. So thanks for giving us a preview of what might be. Tony, go ahead.
Yeah, first off, just want to thank Sarah and the HCMO team. Really, what a extensive and exhaustive body of work, and quite a challenge in front of you. And you guys are doing a remarkable job. And it's challenging in the setting of being discretionary about these, but also the repercussions that we're seeing. And I think Bill and many on the board are very just interested in this is a public forum. This is the means by which we're sharing what's happening to communities across the state. My question, Sarah, and this will be one offline, two items actually, sorry. Is one, I'm concerned as these grow, there's going to be more and more of these reviews, and I think the board should be attentive to equipping HCMO and paying attention to OHA's staffing for this. So I'd be curious about that. That seems like that would be quite a tall order as more of these add up, and which I I would suspect there are going to be more and more of. And then two, a comment to the effect of HCMO is a strategy to review things that are happening, but thinking of being proactive in a investigative look and a proactive look to see why certain community clinics, small clinics, larger size, medium size, as we're seeing this consolidation. I think many of us have seen a lot of research, but I think I'm more interested in seeing what methods we can do to be discretionary as far as, you know, the financials for an organization, but seeing where things on the broader strokes that we can do, perhaps at this level, or influence legislatively to help smaller practices or those medium-sized clinics. And so I know that I just think I offered up to the board and us as this general community and thinking health policy in our state. How can we be equipping clinics to be supportive or not hinder them in the things that we're doing here in state policy? So I guess I'll bring it back to Sarah after that comment. Just the thought of, you know, want to be collaborative as the Oregon Health Policy Board with your team to support HCMO in the work you do, and thinking of the workforce or the tools you guys might need.
Thanks, I really appreciate that. And OHA leadership has also been incredibly supportive of this program and looking at the capacity that we need. We recently added 2 new policy analysts to our team 2 weeks ago to help support the growing volume of reviews. This work is sort of responsive. We don't know when we are going to get a transaction until we get it. And then our workload, once they're in, we have that 1, 2, and 5 year sort of known work cycle, and that adds up. We did some modeling about our sort of doubling and tripling of the workload, and it was a lot. So appreciate the acknowledgement of that. And also we're really delighted that we added 2 new team members 2 weeks ago.
Thanks so much for that, Sarah. Plus your impromptu nature of responding to these requests from the board. So I appreciate you being available today to kind of close the loop on some of what we talked about. And I'm sure it won't be the last time we are, you know, thinking about the impacts of this program. Excuse me. So welcome now to the next topic on the agenda, which is our Healthcare Cost Growth Target Advisory Committee, both the membership appointments and a preview of the public hearing updates. I think I'll turn to Bill, you know, to say a few words, and welcome to you, Sarah, and the topic for today. Bill, as our liaison, what you got for us?
Thanks. Again, express appreciation to Sarah and the team for the great work they're doing in the Cost Growth Target Program. The advisory committee plays a very important role. There's good work underway right now through that, as well as the Rules Advisory Committee. Having the right people on the advisory committee is very important. And I think Sarah's done a good job on identifying candidates to replace those who have moved off of the board or off the committee for one reason or another. So I'll turn over to her. We also have a topic to address regarding the approach for our the joint meeting we're having on in early June, but I'll wait for Sarah to tee that up. I have some comments on that as well. Take it away, Sarah.
Thanks. Can we bring the slides up, please? Awesome, thank you. Okay, so we are gathered here today to talk about new member appointment, and we have a proposed slate for your approval today for the Sustainable Healthcare Cost Growth Target Advisory Committee. Next slide, please. We've come to you a couple of times over the last 6 months to fill individual vacancies here and there as they've popped up, but this time it's a little more comprehensive. So backstory, reminder, oh, sorry, stay on the previous slide, please. Okay, so back in 2022, we worked with the policy board to develop, and you approved, an ideal committee composition matrix, and that has guided our recruitment and committee appointment and filling of any vacancies since then. I think I still really appreciate having this as a guiding document. I think it was sort of a new approach for committees of the board recruitment, and it's been so helpful to have this as a framework, so thank you for that. That ideal matrix looks at representation across 3 different domains. So sector representation, what parts of the healthcare system or other non-healthcare system folks do we have, demographics, and expertise. Recognizing that we don't have one specific one person, one seat composition for this committee, that people bring lots of different kinds of experience, lots of different representation in different ways and can wear different hats. And so we look to balance across these 3 domains in our 20-member committee. Initially, you approved the first iteration of the advisory committee in May 2022. We appointed for an initial 2-year term. So it is now May 2024. That initial 2-year term is up, and we are ready to look at a broader recruitment. Next slide. So for 16 of our 20 members, that initial 2-year term is ending. We have met with committee members individually over the last month and a half to see if they're interested in continuing. Some individuals have changed jobs or have changed what they're doing, and so may not be in the same position to bring that representation to the committee. So we have a sense of who is continuing, who's not continuing, or who would like to continue and not continue. We do not want to replace all 16 members whose terms are expiring. That impact and sort of not having a staggered membership would be really challenging for keeping the work forward. So we would like to keep a number of the committee members and reappoint them, and then strategically make some modifications. So let me tell you what those proposals are. Next slide. This is, just for your reference, the current committee roster as of May 2024. The folks that are grayed out are the ones whose initial term is up in May, is up this month. We have 4 members who were appointed, fairly recently over the last couple of months, as well as later last year, and they are not yet term limited. Next. So we opened a broad call in late March. It was open for about 5 weeks. And in this recruitment, we did not specify which seats were vacant in the recruitment. We just said we are recruiting for committee members, in part because we hadn't finished conversations about which committee members wanted to continue or didn't. And so we didn't know how many vacancies we were trying to fill. And also just timing. So we did a general open recruitment, and we did a lot of our normal outreach efforts. So all of our distribution lists, all of our known interested parties. We did some more strategic outreach to individuals and through the community partner outreach program to try to reach more of the consumer advocate folks. And yeah, and that was all up and open and sort of standard practice. Next slide. We received 11 applications, and this is not as many as I would have thought. And I want to own that choosing to not recruit for specific seats likely contributed to a lower than expected number of applications. So just want to put that out there, like maybe lesson learned next time, could be more strategic about which, what seats we're saying we're recruiting for. When we had 11 applications, we then considered professional lived experience, current committee member representation and interest in continuing, and the overall representation in alignment with that ideal composition matrix. Next slide. Of those 11 applicants that we got, 9 of them were provider organizations. We're really seeing provider organizations pay more attention to the cost growth target program, really want to have more of a voice in the program design and program operations. And so really nice to see strong interest here. We had 1 payer and 1 other applicant. Of those providers, 4 were FQHCs, 2 were pediatric practices, 2 were small independent practices, and 1 was a large hospital health system. So again, as we've had more conversations, as we've talked more and more about the public reporting, the data validation, the accountability, the rulemaking that's going on, we've really seen that provider interest in participating. Next slide. So I guess here's the headlines. We are proposing 4 new members. Of those 16, we would replace 4 and then reappoint the other 12. The 4 proposed new members representing a health plan, Jeremy Vandehay from Pacific Source, Daniel Porter from Legacy, representing a large hospital health system, Poonam Chibber from the Portland Clinic, representing an independent provider, and Colin Stackhouse from Mission Driven Data as a consumer advocate. Next slide. So this shows you what the roster would be with the new members and the reappointments. I can be more specific about sort of who would be rolling off if you have questions, but this is what the proposed slate would look like moving forward. Next slide. And then just to make sure that we're in alignment with our composition matrix, our ideal representation, here is what the proposed slate would look like on those factors and compared to our ideal matrix. So we would have 50% women or non-binary members. We would have 30% people of color. We continue to not have anybody with a self-identified disability or functional limitation. This has been true for every recruitment we have run for this committee since the beginning. This is a known gap. And we would have 15% LGBTQ. So in all except disability, exceeding or meeting our ideal composition. Next slide. In terms of geographic representation, our ideal composition was that 25% of the members would live outside of the Portland metro. You can see that we meet that. We would have 65% in the Portland metro instead of 75. So we're meeting that, but we do lose a little bit of the geographic variation that we previously had. We would no longer have anyone from Southern Oregon or the Willamette Valley or the coast with this composition. And that is in part because we have an increase of folks who don't live in Oregon. We have some folks who work for companies that have presence in Oregon and certainly represent and provide services to members in these areas, but may live in Southwest Washington or maybe otherwise out of state. Next slide. And then finally, expertise. We easily exceed all of our desired expertise in our proposed slate. I think we just continue to strengthen what we're seeing here. I think I'm continually impressed with the number of folks across all of the sectors, industry and non-industry, who bring expertise with affordability and consumer costs, as well as ensuring equity in policy making. All right, and I think last slide, just wanted to turn it back to you. Any questions? Would love to bring this to you for your approval and reappointment.
Go ahead, Bill.
Sarah, one of the things you mentioned early on was about the importance of balance between people who represent organizations that are subject to the cost growth targets and those who are not. Purchasers, consumers, other community members. But I didn't see a slide on that. Could you just give us what the breakdown is to ensure that we have the continued appropriate balance between those different groups?
Yeah, so our sector split is 50-50. 10 members represent payers and providers who are subject to the cost growth target, and 10 members represent consumer advocates, consumer representatives, purchasers, and employers. So we maintain that balance with this proposed composition, this proposed slate. And in fact, we actually maybe improve it a little bit, because previously we had one provider representative who was from an organization that turned out to be too small to meet the threshold for inclusion in the cost growth target program. And so we're proposing a new member who would represent an organization who is subject to the cost growth target program.
Great, thanks for that clarification. If there's any other questions, we can do that. Otherwise, I would put on the put forward a motion to approve the advisory committee slate as presented.
Thank you, Bill. Is there a second?
This is Carly, I'll second.
Thanks, Carly. Further discussion? Seeing and hearing none. All those in favor to accept the slate as proposed, please signify by saying aye.
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 Any opposed?
Opposed.
Thank you, Dr. Hemmings. Any abstentions? Okay. Thank you very much. Any other comments or reflections on the composition of the committee before we move to the second item for today's conversation? Okay. Sarah, next is a preview of our June meeting, I understand. Is that to you to share, a draft agenda perhaps? Okay.
Yep. So Bill, did you want to do any framing before I talk about the weeds?
No, go ahead, Sarah.
Okay. Sorry, you're getting a lot of me today at this meeting. So as you know, thank you for agreeing to host this year's cost growth target public hearing at your June board meeting. So that will be June 4th. The plan is that that will be a hybrid meeting, virtual and in Portland. I believe the plan is that the first 30 minutes will be board business, and then from 9 to 12, we will hold the annual cost growth target public hearing. So I was hoping that we could spend a little bit of time today talking about your desires for that public hearing. We've had 3 public hearings for the cost growth target program to date, and they've all looked a little different. And so I think we have some options for how we design this hearing. And I have 2 very high level proposed agendas that were in the meeting packet that sort of give 2 different direct paths for the public hearing. So I can talk to you about what they are, and then would love to just hear your sense of which of those paths you would prefer, maybe a third path that we haven't thought about, and then maybe some other prompt questions to help us put that agenda together and work with all the panelists and all of that. So path 1, agenda option 1, is a little bit more focused on presenting the data. So highlighting what we know about cost growth trends in Oregon, what are the key cost growth drivers, how are we doing as a state in meeting the cost growth target. That would be state level, market level, payers and providers. How are payers and providers doing? I think this would also be an opportunity for us to really bring in some of the data on consumer impacts about costs and affordability. We have some new data coming in that we hopefully would be able to release and present as part of that agenda, and we'd be able to have that sort of grounding this conversation in the consumer perspective on affordability. We, in this proposed agenda, would have some time, but maybe not the full meeting, for some sort of panel. And I think one of my questions for you is like, who do you want to hear from? So this could be a panel to hear from payers and providers about their performance. This could be a panel about employers or consumers from their perspectives on affordability. But it would be more focused on sort of presenting the data and a venue to highlight that, maybe some questions, opportunities to understand, and then a bit of a panel discussion. The second path would potentially be more focused on hearing from payers and providers. This might look more like where our sister state Massachusetts is bringing their cost growth target hearings to, where they bring panels of payers and providers, or other key contributors to cost growth in the state based on the data, and have a Q&A, have a panel and say, what are you doing? Why did you exceed the cost growth target? What's going on? And so an opportunity for some of that back and forth. We would have some high-level summaries of the data just to ground everyone, but the focus of the hearing would be on an opportunity to hear from payers and providers. And if that's the path you want to go, I'd love to ask you, which payers and providers, those who met the target, those who didn't meet the target, some mix. So I think this could be more discussion oriented. I think there are some pros and cons of this approach as well. We did this, we had panels of payers and providers in our September 2023 public hearing. Many of you as board members helped facilitate and moderate that. Thank you, it was great. I think that conversation, those panels were more of a presentation and less of a Q&A or a discussion. And I think we could propose either for this year. Do you want to hear presentations from invited panelists, or do you want to have an opportunity to question payers and providers, or something else entirely? So I think those are our 2 starting proposals for your consideration, and would love to hear your reactions, or like I said, your desires for the public hearing.
Thank you, Sarah. Bill first, and I saw Kirsten also, perhaps. Yeah, Bill, go ahead.
Okay, thanks very much, Sarah, and appreciate your presenting these 2 options for our consideration. My recommendation boils down to more discussion, less data. I think we can get the information through other means, through reports, through sharing of slide decks in advance. A summary is fine, but I think the unique thing about having a meeting is having discussion and having feedback from board members, from others, from stakeholders about the program. It's really important to get this right. Since the state really does face an affordability crisis, cost growth target program is one important tool, and getting it's important. So understanding not only what the cost drivers are from the provider perspective, but also the impact on consumers and purchasers. And so that's the problem side, and that we also begin the conversation about the solution side. Which I know is on the agenda for the Cost Growth Target Advisory Committee in the upcoming months. So there's a lot to pack in there. I think it needs to be organized well, but and I'm sure it will be. I would recommend that we use the time, the valuable time for structured discussion and feedback, and less time on presenting the data, which I think is where you're headed with option 2.
Thank you, Bill. Other feedback or questions? Tony, go ahead.
Yeah, I really appreciate those comments, Bill. I echo those sentiments as far as having the opportunity to have more discussion, the panels, the opportunity to present. I think that if we can take a look at some of that data that we might have in the first layout, just to share that with us, I would value spending time looking in that in advance rather than at that time. I think it'd be more as well. I would be interested also in these panels, and I'm sure, Sarah, you'll bring together and a staff and being thoughtful on these panels of best practices that we've seen and models that have worked, and elevating that work. I think it would be great to see that. I would also like to see what have we done? What has been implemented at the cost growth target? What were the barriers to that? What were the challenges? What were the failures? It'd be good to hear the failures. It'd be good to see where we leaned in on this work and where we struggled to accomplish some of those tasks. And we know there are many, but I think hearing about those can be constructive to shape that and be thoughtful of how we might move forward in a different way. So I'd like to see, something maybe in that panel of, what are those struggles that different levels of healthcare we're seeing? And, I think it'd be instructive to look at healthcare delivery along with the payer. And I'd have to think that through a little bit better, what that would look like. But there are multiple aspects to this. There are many pieces to this equation. So I'll give that more thought and frame that a little better.
Thank you, Tony. Kirsten.
Yeah, I really appreciate you bringing this question to us, Sarah, and your team being so thoughtful about the approach. I have a couple of reactions. Sorry if everybody else can hear the trash truck outside my house right now. Hopefully not. As someone who helped recruit some of the consumers who spoke in the past, those stories can be hard to share, and I'm I have a lot of appreciation for the courage of those who do it in a public space. And part of my conversations with those people was about kind of investing in change in the future. And I would like this next hearing, now that we're into this program a few more years, to start to really reflect that transition to action, I guess. And when I say that, so I appreciate the kind of value centering that comes from like, well, let's hear where let's start from the consumer perspective and stuff. And at the same time, I'm like, oh, what I think consumers deserve to see at this point is to actually like hear, how is it working? Is it working? And to me, I think that looks like really highlighting those who met the target and having them share, like those who leaned into this and did the hard work. Let's celebrate them and like give them that spotlight that they earned, and kind of use that as an example. So I'd like to hear about the hard work that people did that let them succeed under this. And then the kind of converse of that, I think there were some that didn't lean into this. We still have exceptional waste in our system that is hard to address and stuff. But I guess I would like to have a little bit of celebration of those who leaned in, and acknowledgement of those who didn't. And I don't know quite what the questions would be, because I kind of don't want to make a platform for like a tap dance or excuses. But I do want to use this here and to really underscore, like, we are doing this and we are moving forward. So there will be challenges that we need to address, because this work is not easy. And how do we hear those and find the solutions to those barriers? But also, how are we holding people accountable and rewarding those who held themselves accountable? So I think that makes me lean towards the second.
Thanks, Kirsten. Thank you, Melina.
Yeah, thank you. Thanks, Sarah, for bringing up the two options. And I agree. I like option 2 with the panel. I think we can get the data by other means. On the panel, Kirsten, I agree the consumer stories are sometimes very difficult to hear and also very difficult to tell. It's created a lot of medical trauma for a lot of people. But I think those stories do need to be retold, because if we forget about why we're doing this and why we're creating these policies, sometimes it gets lost in the higher levels, and can be forgotten of who and how these policies affect. With that, I think we should definitely highlight the ones that exceeded and met the goals, and then which can be models for the ones that didn't. On the panel, it also, gives the opportunity for the ones who did not meet the expectations, for them to highlight their challenges, not necessarily their excuses, but why didn't they? So then a solution can start to be developed for them. So yeah, thank you. Option 2 is my preference.
Thank you, Sarah. Just a few thoughts, and then I'll turn it back to you. I think hearing is consensus around option 2, so more engagement. As we prepare the panelists, it strikes me that it would be useful to encourage them to think in advance about the known drivers, so like isolating or not isolating issues that are common across. So for example, wage inflation, and workforce costs subject to, how much was it conditional to or not to meeting or not meeting the specific target. Technology might be another, or regulatory requirements, et cetera. So really helping people frame this is what we're seeing, and to the extent that they have capacity to really analyze their own information to understand their own drivers, or how the program might really support them in unpacking that, and to what extent you actually have visibility into that as OHA. I certainly want to double down on the notion of identifying what's working as a way to build kind of community in this territory together and avoid issues or kind of the implications of shame that might come up for people, at least in the provider kind of side or in the health plan side of this really important conversation. So that notion about like how we're integrating consumer voice, how we're integrating the provider payer voice and understanding the, it's not a finger pointing kind of a game. It's really the idea about how we get underneath some of the drivers and then collectively think about how can we respond instead of really calling out anyone. I think specifically about things that are really troubling. So that I think, there's some latitude for it in a public context, but I think generally people don't motivate their own behavior based on issues of shame. And so what I'd like to do is kind of think about like, how can we support, this orientation that matters to us all. So with that, Sarah, reactions. Oh, I saw your hand, Bill, go for it.
Yeah, just a quick thing, agree with everything people said. I just want to double down on Melina's point about the importance of the patients and consumers and employers' voice. And hopefully it's not people who just suffer medical trauma. That is very difficult to get people to come forward, but just there's financial trauma as well. People who literally, have to face serious financial circumstances because of the high cost of healthcare. I think having their voice, if we can, I think we should be able to find folks who can do that effectively and compellingly. That's just, it grounds us. That's the reason we're doing this. And so I want to be happy to work, Sarah, with you and others to find the right folks.
This is so helpful. Thank you. I agree. I definitely heard consensus for option 2, noted. In terms of receiving the data in another way, we do plan to publish the 2024 cost trends report in late May. And that we'll be spending our May cost growth target advisory committee meeting presenting the data. So we'll make sure board members have that invite, get the report. And if you want to hear sort of the presentation of the data, that will happen in that space. I did have a couple more questions, which maybe are a little in the weeds. Feel free to, reflect and email me if you have other thoughts, but we have a lot of payers and provider organizations that are subject to the cost growth target program because we have a very broad net and we look at all markets, Medicaid, Medicare, and commercial. I can think of a number of ways to organize panels. Last year, we did it by payer and then provider. We had separate panels. We could do that again. We could organize by sort of type of provider, large providers versus pediatrics or FQHCs, hospital affiliated versus not. We could organize by market. The drivers, the experiences are different if you're talking about Medicaid versus Medicare versus commercial. Certainly we can do a little bit of both, but in terms of an organizing principle, do you have any immediate thoughts about sort of sector organization versus market organization?
Geography would be the other one I would be interested in, rural versus metro, or urban. And I wonder, Bill, if this a good role for you as the liaison to noodle with Sarah a little bit, in terms of the more specific layers of orientation. I know we're at time, but I did want to, I don't want to, let's see, what I want to do, Sarah, is make sure you get your question answered. And curious, Bill, if you are the right person to help us do that.
Sure, happy to work with you, with Sarah and whoever else is interested in this, helping to put this together. Sarah, a quick response on the sector stuff. I think, subject to changing my mind or other input, that focusing on commercial sector is most important. Medicare and Medicaid have other dynamics they have price controls, whereas commercial doesn't. And so that's the majority of people in the state. So I think that might be the appropriate area to focus on, because it is different than Medicare and Medicaid. But there's lots more. I know you have other questions. Happy to work with you offline to help shape this to its most effective, support the program and support the public interest in this.
Thank you so much, Bill. I will reach out and we'll coordinate. And then I think individual board members, we may also reach out for questions about moderation or facilitation, for any of the panels, as well as if you have ideas or helping I invite or confirm panelists. So more individual requests coming soon. Thank you so much.
Good. Thank you so much, Tara. Great presentation, Bill. Thanks for your work on that as well. All right, we're now at time to welcome in our Health Information Technology Oversight Council, all of our high talk folks. So I know that we have one board member, Carly, although you're not officially serving in the role of a high talk liaison. You've had some great experience with this committee, and I wonder if I can turn to you to welcome the team to today's conversation.
Yeah, absolutely. Thanks, Brenda. I'm incredibly happy to introduce you to High Talk's work today. And the reason I'm doing that is that before joining OHPB, I was a member of High Talk and had the pleasure of working with the team, both the staff and the committee itself to consider information technology and implications across the state. So I'm really excited to see what's happened in the months since I stepped down, but High Talk plays a really important role in setting a clear direction for health IT in Oregon. I was, really excited to serve as the chair for one of the work groups that High Talk developed on community information exchange. That is information sharing between social service and community-based organizations and healthcare entities. And this is an area that has exploded over the last several years. So as part of this work, we brought together a table to discuss the opportunities and challenges within CIE, or Community Information Exchange, identify actions and strategies to move this work forward. And there have subsequently been other parallel work groups working on HIE, health information technology, and other pieces of technological infrastructure for the state. So I can really attest to High Talk's commitment to community engagement and equity. There was a lot of work within the CIE space that consistently centered equity and was supplemented by deep engagement of community-based organizations who are doing this work every day. And I'm sad to have stepped down, excited to be in this space, monitoring from a different perspective. But I'm really excited and glad that the board will have an opportunity to hear and support their work today. So with that, I think, Susan, I'm turning it over to you.
Great. Thank you so much, Carly. I'm Susan Otter. I'm the Director of Health Information Technology and Analytics Infrastructure for the Oregon Health Authority. And I'm pleased to bring our team and our High Talk Chair and Vice Chair to present to you today. I think we're ready to bring up the slides. So let's see. I think we'll do quick introductions. Hope, do you want to introduce yourself?
Sure, thank you. Hi, I'm Hope Peskin-Shepherd. I use she, her pronouns. I'm the Community Information Exchange Policy and Program Lead in Susan's office. And also I was the interim strategic planning lead for about a year. Laurel?
Great.
Morning all. My name is Laurel Moffitt. I use she, her pronouns, and I'm the lead analyst for High Talk.
Great. Dr. Henninger, would you like to introduce yourself?
Good morning, everyone. Amy Henninger, she, her pronouns. I work for Multnomah County Health Department in our Community Health Center, FQHC. And my role there is Primary Care Medical Director, and I am the High Talk Vice Chair since 2017, which is now a very long time ago. I can't see everyone on the call, so Susan, do you want to?
Sure. And then David Dorr, would you like to introduce yourself?
Sure. I'm David Dorr. I use he, him pronouns. I'm the High Tech Chair. I work at Oregon Health and Science University, where I'm an internal medicine physician and an informatician, as well as the Chief Research Information Officer.
Great. Next slide. So today we're going to start by talking a little bit about High Talk and Health IT, and then we have a draft strategic plan for Health IT that High Talk has been working on for quite a while. So we'll review the draft and look for your input. We're really looking to see, make sure that this strategic plan is directionally in alignment with the board's priorities and goals, and we'll seek your support for that strategic plan today. And then we do have a slate that we'll be proposing, so we'll save some time to walk through the High Talk membership. Next slide. Great. David, I think we're going to have you introduce High Talk and its role.
Yes, thank you. So as chair, I will introduce the Health Information Technology Oversight Council. The Oregon legislature established High Talk in 2009, and really the intent was to ensure that our Oregon's health system transformation efforts are supported appropriately and well by health information technology tools that include electronic health records, but also have several other types of information exchange mechanisms and systems like health information exchange that allow us to connect systems to coordinate care, both to support health system transformation and more recently, especially with the strategic plan focused on health equity, which I think we all know Health IT has a really interesting relationship to equity. So we bring partners together across Oregon to work on these responsibilities, advising on health IT strategy and policy, monitoring the health IT landscape, and then developing these recommendations, including the state health IT strategic plan, which is what we're focused on today. And we provide expertise to all of you, and we're happy to, including and policymakers, including the impact of federal policy changes, which have been coming fast recently. So we appreciate that. So we really want to focus on this Oregon strategic plan for health IT. The period for the strategic plan is 2024 to 2028, and it sets the priorities for the partners in the health IT landscape. Really vital for us, for the partners working on health IT, and to set a clear direction for health IT priorities. As I mentioned, there was a lot of incredible discussion and work here, and it really goes above and beyond the previous strategic plans from High Talk in its focus on thinking about health equity and focusing on patients, right? So these focus areas are newer to some areas of health IT, and so having this clear roadmap is very important for equity and community-based strategies overall. And then also we focused on providers that might have been left behind in some of the historical supports for health IT. For instance, we focus on behavioral and oral health providers and providers in rural and remote areas that need additional support, take advantage of health IT. I do want to say how much work the staff put into this. It's incredible, and the committee had amazing discussions on this, and so I think it really sets an important tone for health IT in Oregon. And really today we want to make sure our priorities are aligned with yours, those of the board, and that we're moving in the right direction. I'll pass it back.
Great, thank you. Okay, so what is health IT? David touched on this a bit. Health IT is technology that is used by individuals, providers, health systems to collect, store, access, organize, and share health information. It includes electronic health records, which are foundational for capturing a patient's record, health record or chart. Having that information in a digital form is kind of a prerequisite for helping to make that available across organizations through health information exchange. When we talk about health information exchange, we often use the verb to exchange information electronically, and also the noun, an organization that supports the exchange of health information. So health information exchange is really critical for coordinating care for across providers and organizations that are serving the same person. We also have patient portals where patients are able to log in to your provider's EHR patient portal and look at your own health record, engage with your provider, see the full clinician notes for a recent visit, discharge summaries, medications, et cetera. Next slide, and I will pass it to Hope.
Thank you. And as Carly and Susan, I think, have mentioned so far, another example of health IT is called Community Information Exchange, or CIE. And this is a network of collaborative partners using technology to exchange information to connect people to the services and supports they need. So the graphic here explains this process a little bit more. You can see here on the left, a person seeking help is referred to services they need through the CIE platform, typically working with someone who here we're calling a helper, someone at an organization like a community-based organization, another type of service provider, or it could also be at a healthcare organization. And then the CIE platform documents information about the person's needs, as well as their consent to share their information. And this organization helping them can search for appropriate resources in CIE and send a referral to the appropriate organization. And this receiving organization can indicate if they are able to provide the services, so that that first organization who referred them can see what happened with the referral. And this process is known as closing the loop. So I just want to take a minute to share a little more about the current state of CIE in Oregon, and also how it can support closed loop referrals for health-related social needs, or HRSN. And under the 1115 Medicaid waiver, HRSN services can address climate, housing, and nutrition supports and outreach and engagement. And there's a requirement under the waiver that requires closed loop referrals for HRSN. And CIE technology is one thing that can support this, as closed loop referrals are one of the main functions of CIE. So as I mentioned before, closed loop is where the information is exchanged among those helping a person in need to make referrals and communicate about the status of the referral for services. And communities across Oregon are implementing CIE. Existing efforts have been largely sponsored by CCOs, health systems, and health plans, and adoption of CIE varies for different CBOs, providers, and other CIE partners. Next slide, please. And now we're going to turn to the Oregon Strategic Plan for Health IT for 2024 through 2028 draft developed by HighTalk. I'll touch on the purpose of the plan, a bit about how it was developed, and some of the content at a high level. I'll also just note there was an education session about 2 weeks ago that had more detail, and today I'm going to stay at a higher level. The recording is posted, and also the full strategic plan document is a meeting material. And again, today we're looking to you, the board, to ensure the strategic plan for health IT is going in the right direction and see if it is something that you feel you're able to support. Next slide, please. So what is the strategic plan for health IT and what does it do? The strategic plan sets high-level direction for health IT statewide over the next 5 years. HighTalk is the author of the strategic plan, and through the plan, they identify the highest priority work and help partners coordinate their efforts for the benefit of statewide progress. And the plan is for everyone using or impacted by health IT in Oregon, which includes individuals or consumers and patients, providers and clinic staff, the 9 federally recognized tribes of Oregon, community-based organizations or CBOs, hospitals, health systems, coordinated care organizations and health insurance plans, technology partners, and state agencies. And the strategic plan emphasizes which is the board's central priority for 2024, and OHA's strategic focus through 2030. The plan prioritizes patients and consumers' engagement, access to data and rights, and it prioritizes providers that have not had as much support for health IT, namely those in behavioral health, oral health, and rural settings. And the stars indicate areas where health IT improvements in the strategic plan support board priorities. The strategic plan is needed because OHA's efforts to make healthcare more equitable and improve the healthcare system need support from effective health IT. Also, these technologies have not reached everyone equitably in Oregon. Despite rapid expansion of health IT in the past decade, some gaps remain, and these gaps can contribute to health inequities. And lastly, coordinating health IT efforts at the state level is important because there are so many moving parts. Next slide, please. This timeline here summarizes the extensive work that went into the draft strategic plan, including years of high talk discussions and exercises, work group reporting, and significant community input. Prior to this timeline, there was also foundational work and initial community engagement, which paused in 2020 due to the pandemic and then resumed in 2021. So High Talk chartered 2 work groups to inform their process, one focused on CIE and one on HIE. I'll touch more on community engagement in a moment, but engagement was ongoing throughout the process and also iterative. High Talk made changes to aspects of the strategic plan based on input, and then also identified groups they needed to hear more from, resulting in additional community engagement as well. Also, High Talk worked through aspects of their strategic plan at meetings, with all of this coming together and culminating in a retreat December of 2023. And then High Talk received and reviewed their draft plan and approved it in February. And since then, the draft has been reviewed by OHA's External Relations Division, including an equity assessment and the 9 federally recognized tribes of Oregon. And then here we are today, all the way on the right side. 2 weeks ago, there was an OHPB education session, and today we're here at the OHPB review step. Next slide, please. So here are some highlights from the community engagement. As I had mentioned, the strategic plan was informed by extensive community engagement, and this was across 51 engagement opportunities with hundreds of people, including consumers, providers, health systems, and community organizations. And these opportunities included existing input on health IT from High Talk's previous efforts, as well as work from other parts of OHA being brought in, and new listening sessions, public comment, and written input. High Talk hosted listening sessions at different points throughout the strategic plan process, and incorporated relevant information from past sessions as work developed. High Talk also prioritized key groups that were not reached in previous discussions, namely behavioral health providers, long-term post-acute care, rural communities, and also health IT staff from carceral settings like prisons and jails were also met with. And this slide also shares some quotes from listening session participants. I'll go to the next slide. So the strategic plan is made up of 5 components that work together to advance health IT. The vision is High Talk's overarching future direction for health IT in Oregon. The goals are broad, long-term desired outcomes. The strategies are a plan, policy, or focus area to achieve multiple long-term goals. And then the activities under the strategies outline steps and actions to achieve the strategies. And the principles are values that guide and inform each aspect of the strategic plan and should be taken into account at every level. We'll share highlights of the activities today, and the full information is in the strategic plan document. And I'll just note that High Talk designed all 6 strategies to support their goals. And it's also important that the principles apply to all of the components of the strategic plan. Next slide, please. So HITECH's vision in the strategic plan for health IT is that health IT empowers individuals and communities to reach their full health potential and well-being. And this also aligns with the health equity goal. And all of the goals also support health equity, and they are that people can be actively involved in their care through access to health IT, that individuals' information is electronically available, exchanged securely and seamlessly, that health IT supports efficient and accurate data collection, sharing, and use, and that health IT design, implementation, and use must center health equity. And so I'll also on the goals just note a few things that the first two in particular support greater patient agency. If we can just go back a slide briefly. That the first two support greater patient agency over their information, which also supports health equity. And the goal D is focused on health IT supporting health equity and also social determinants of health. Let's go to the next slide. And HITECH's principles are that health IT must advance health equity and avoid reinforcing or worsening inequities. The equity of people's health information is ensure individuals and communities understand how their data is stored, shared, and used to provide transparency and grow trust. The fourth one is to leverage existing resources and align with national standards. Next principle is to improve efficiency and avoid adding burden. And lastly, ensure efforts are sustainable with thoughtful, intentional progress. And number one is starred because it aligns with OHPB's 2024 priority to advance health equity. The fourth one is starred because it supports reducing healthcare costs, as lack of alignment can raise costs and makes connections between organizations more complex and challenging. And the fifth principle aligns with metrics alignment. Next slide, please. So HITECH identified 6 strategies to achieve the strategic plan goals. This slide has the first 3, and then on the next slide, we'll have the next 3. And I will share highlights of the activities that HITECH identified for each of their strategies, but the strategic plan document has pretty extensive detail on the steps and actions that would support each. First strategy is to strengthen engagement, access, and rights of patients and consumers. And centering patients and consumers in health IT improves care quality, trust, and equity. And activities include increasing patient and consumer agency over their health information, and also to strengthen accessibility of health IT. The second strategy is to close remaining EHR gaps, including by prioritizing resources for groups with lower EHR adoption rates, such as behavioral health, oral health providers in rural areas, long-term care, carceral settings, school-based clinics, and small independent physical health providers. The next strategy is to spread HIE across the state. Efficient HIE helps improve care and care coordination. And some of the activities that support this strategy are to encourage more participation in HIE networks, to provide funding and support for adoption, and to make more data available for HIE. And we'll go to the next 3 strategies, please. On the next slide, please. Thank you. The fourth strategy is to support, accelerate, and improve statewide CIE efforts. And this strategy seeks to overcome barriers to coordination among social service providers, CBOs, healthcare, and other organizations working to meet people's social needs. And activities include providing support for CBOs and partners to participate in CIE, including funding and technical assistance, and that OHA and ODHS should support and participate in statewide CIE efforts by using CIE where appropriate and supporting CIE advancement efforts. Fifth strategy is to improve interoperability and encourage broad sharing of data. This strategy seeks to help health IT systems and tools connect so they can share needed data quickly and easily. And so activities that support this include creating opportunities to facilitate interoperability and identifying which data is useful for which provider, using that data for sharing. And the sixth and final strategy is to evolve governance of health IT efforts. This strategy aims to further approaches that improve coordination and consistency among health IT efforts in Oregon. And activities focus on clarifying and defining governance and also developing governance principles. Next slide, please. Thank you. And here are all of the strategic plan components all together. And HiTalk envisions all these elements working together to support the vision. They'll be useful to partners across the health IT landscape in the next 5 years as they decide where to focus. And we're excited to see how partners will use this plan to improve health IT and advance health equity. And now I want to invite Amy Henninger to share more about the impact of this plan and the plan can have on clinicians and patients.
Yeah, thanks, Hope. So for me, my interest in health IT is multifaceted. As a primary care provider, it's really important to be able to have access to information from specialists and hospitals, and that information and the access to that information has greatly improved the quality of care that I provide. Also being able to communicate and share information with other providers means that I can make important health decisions faster. The strategic plan contains strategies and activities that support not just providers that we provide care for. It's important to me that health IT can share data efficiently so we don't have to spend time entering data in over and over. Minimizing that duplication means I can spend more of that precious visit time with my patients. Health IT also brings value to the experience of my patients. A few ways that it can improve their health are number one, through accessing their own health information, for example, through a patient portal that's connected to their provider's electronic health record. Number two, by using messaging or patient portals connect with their providers, connecting the patients to their providers and care team. And number three, patients are using technology to collect and track their own health. And then personally, I like to be able to share a note with patients when I'm sharing lab results, for example, through our patient portal. I get some occasional really fun messages, like a midnight message from a patient, which I didn't see at midnight, who had just had her baby, just saying, hey, I had a healthy baby. I just wanted you to know. I think the strategic plan here really supports patients and providers and moves health IT in Oregon in the right direction. And I encourage you to support the plan. Thanks.
Great. Let's move to the next slide. I think we're ready for questions and discussion from the board on the strategic plan.
Thank you, Susan. Board members, questions, reflections? Please, Melina.
Yeah, so thank you for this. I appreciate the work as a consumer of healthcare and also a provider of healthcare. The health IT is very important. I use it every day. One thing that I appreciated was how much you addressed health equity in providing the HIT and the CIE. One thing that I'm concerned about is our rural communities and the lack of internet going forward, and how how this is going to be addressed is, or if this is a consideration in your plan, because without the infrastructure and no access to internet, you know, the consumers have no access to their own medical records. So that was just one consideration.
Thank you. Absolutely. High Talk considers, you know, access to the internet, high-speed broadband to be, you know, foundational for the work that we outline in the plan. Are a number of efforts going on in Oregon of broadband that's not just healthcare related, but broadly in Oregon. And so we recognize that as a kind of a foundational effort, and that the strategies out of that office are really critical for this work. So.
Thank you, Melina. Is another questions? Kirsten.
I just wanted to comment that, like, you know, your initial question is this strategic plan directionally in line with board priorities? And I just, even when I was quarterly and you know, under High Talk, I was like, oh yeah, we're hitting all these things. Yeah. And I just to me, this is an incredible reflection and coordination of goals. And I see High Talk filling in some spaces that, if left unfilled, like we won't achieve our goals. And so I particularly appreciate the work that you're doing around the community information exchange and recognition that, like, it's not just creating this tool, but like, how are we helping making sure everybody can use it? And those are not small challenges or tasks. And so I see this as really in line with the board priorities. I appreciate the work that went into it, and I appreciate the efforts, you know, that you're filling in these very critical empty spaces that will enable progress. Thank you.
Thank you, Kirsten. Carly.
Yeah, I think Kirsten well said, and I have the advantage, of course, of having been involved in some of this before, but, you know, it struck me multiple times, even today, just thinking about how interconnected this is with all of the other issues we've been talking about. Like, workforce challenges are directly related to having poor or solid infrastructure technologically underneath you. Yep. Being able to share data and look at, you know, inequities itself is directly related to technological capabilities. So I too really feel like this aligns really well with so many of the kind of key things we continue to hit on as a board, and really support the work of Susan's team and David and Amy's leadership within High Talk.
Thank you, Carly. Tony.
Yeah, just really appreciative of the work and the attention to the question of equity and access to this technology across Oregon. I did have a question related to things we're doing at the state would have really good intentions, but in smaller settings are really hard to accomplish. And thinking about a smaller practice or a community-based organization, and I was really pleased to see, you know, some of the focus on and enabling tools like health-related social needs and accounting for that. But I think of a lot of the metrics that we account for and thinking of the work that HiTalk does. I know my org spends a great deal of money and a great deal of meeting time reflecting on the investments we're trying to do as far as SOGI questions, Real D, but also metrics and a focus on our rural communities, our smaller clinics, and again, our CBOs to make sure that they're having the tools they need to get that quality information and us to be able to make policy changes on that. But more, I'm just thinking, is there attention to that technology requirements? And I just wonder if we could speak to that. If I'm rambling here, but I think really the question is for some of the regulatory things for our OHP members and for our collection of data in those settings that are more challenging to get that. How are we supporting those smaller entities across the healthcare landscape?
Well, thank you for the question. You know, part of HiTalk's role is to monitor the adoption and use of health information technology tools, data, actually, looking at barriers and strengths around adoption of electronic health records and health information exchange. In terms of the focus on the strategic plan around smaller organizations, behavioral health in particular, oral, rural, you know, our goal area, strategy area on electronic health records is to fill in the gaps that remain. We've heard from behavioral health organizations in particular that the size of the organization is, you know, we still have behavioral health organizations that are small that are on paper, and the kind of level of investment into an electronic health record for those organizations is they don't find as warranted based on their size. And that's a real barrier and problem. We had federal meaningful use incentive payments that were available to hospitals and providers that largely benefited physical health providers. And so we see better adoption in the smaller physical health provider space than in those in behavioral health, for example. So the other thing, we have some strengths around health information exchange in that tools related to exchanging health information don't necessarily require an electronic health record. So you could be a smaller organization and be able to access through a patient portal, the health information exchange consolidated client record if you're in a community that has Reliance eHealth Collaborative as a community health information exchange. Certainly for CBOs, participating in community information exchange is through web-based, you know, just signing in through the internet. So there's sort of, you know, the ability to tap into these tools without, with kind of a lower bar in terms of the infrastructure you have to have. That being said, we heard really clearly from community-based organizations about CIE adoption, that about the importance of having financial and technical assistance support for onboarding to a new technology platform, for training, for having staff that can manage that interaction with that platform. So I think now I'm rambling a little bit, but you kind of touched on some of the major challenges that we're trying to address with this plan, and that I wanted to give you a sense of the landscape part of that as well.
Appreciate it. Thank you.
Thank you, Susan. It leads me to a question also inspired by Dr. Hemmings, your chat around consumer engagement and consumer contribution to the plan itself. Can you say a few more words about themes that you heard from consumers, how you integrated that feedback, much like what you just did with community-based organizations, and how we see it in the plan itself? Yeah, thanks, Susan.
Sure. So High Talk has always been focused on, had some goal focused on patient portals and the ability for consumers, meaning patients or clients, individuals who are receiving care in the healthcare system, to be able to interact and access their own health information. What we heard from our High Talk members who represent consumers and peers, as well as from the engagement we had with consumers, patients, advocates, was, yes, that's important to have access to my own health information through like a patient portal, but also the importance of patients being able to have their voice heard in a governance setting where decisions are being made. The first strategy, or one of the strategies, really focuses on that patient piece and the individual piece. And this strategic plan goes further than our past plans have around, nothing about me without me, is the quote that, got said multiple times in our interactions around this work. So really thinking about, as decisions are being made about rolling out community information exchange in Oregon, in different regions, or health information exchange, or the accessibility of tools that providers are rolling out, we heard that patients need to be a part of those decisions and have a real voice. So that's one of the things that we highlight in the plan.
Thank you, Susan. Other remaining questions? Okay. I will join in the comments I think already stated, including the educational webinar that you all hosted for us as a testament to the quality and the depth of the work that's before us as a group. So again, just kudos, hats off to each of you and those who helped, review and engage the communities in the ways that you described, in the entire committee for this extraordinary work. Carly, would you like to do the honors as this kind of quasi liaison role that you've been playing for us? Yes, go ahead.
Yes, I would love to entertain a motion to approve the strategic plan and direction that High Talk has put in front of us.
Thank you, Carly. And I know the word support is on our screen, and I think both support and approval, just recognizing that I think this decision-making is a little bit outside of our group or our purview. So support sounds right. Carly, if you're okay with that.
Yeah,
great.
Absolutely.
Great. Thank you. I saw Tara's hand raised. I may have just covered her. Okay, great. Is there a second in support for this plan?
I'll second.
Thanks, Kristen. Perfect. So it's been moved and seconded. Other discussion? Okay. Seeing and hearing none, all those in favor, please signify by saying aye.
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 Great. Aye. Any other opposed? Any abstentions? Okay. Congratulations, Susan. And again, thanks, hats off to the whole committee for all of their hard work in doing this as well, and the staff. Yeah, thank you.
Thank you.
Good. So we've got one other topic, I think, for you and us, which is the proposed membership slate. Do you want to walk us through that?
That's great. Yes, let's go to the next slide, and Laurel will walk us through our membership.
Thank you, Susan. I am the High Talk lead analyst. Again, my name is Laurel and I use she, her pronouns. I'm excited to share with you our proposal for High Talk membership, including the recruitment process, outreach, and a slate of both new and renewing members. More details on all of the High Talk members can be found in the proposed membership slate document that was provided with the meeting materials. You can refer to it for more information as I discuss our proposal. Next slide. Our goals for 2024 recruitment was to fill up to 7 seats with candidates who can represent groups using and impacted by health IT across Oregon. High Talk's bylaws allow for a total of 11 to 15 members. A few members' terms ended in the past year, and as Carly said, she left High Talk to join the board, of which we're very proud. So currently High Talk has 9 members. This includes 18 voting members and 1 non-voting or ex officio member, Mark Hetz, who's the executive director of HIT Commons, a public-private partnership with OHA that advances health IT adoption and use across the state. So of the 9 current members, 5 have terms that will expire this year and have applied to renew their membership with High Talk. The High Talk chairs and OHA staff recommend renewing all 5 members' terms for 2 years. And that leaves up to 7 open seats. Today, I will share information for 6 new members that we recommend be appointed to High Talk. One of the 7 open seats is reserved for a tribal representative and is currently open. In the past, we were fortunate to have a tribal representative from Yellowhawk Tribal Clinic on High Talk, and we welcome other tribal representatives should they wish to join. On the next slide shows the process that we used for recruitment. We started with a gap analysis of current High Talk membership and then developed an outreach plan based on the priority gap areas. Applications were open for 7 weeks in January and February of this year. Then staff reviewed and scored applications based on a predetermined rubric that emphasized areas like lived experience and leadership in equity areas. We conducted several interviews, and then we worked with the High Talk chairs to select the draft slate that we are presenting today. The next slide shows more information about the recruitment focus areas. The gap analysis tool that we used was the one designed by the OHPB Committee Membership Work Group and the Equity and Inclusion Division, and it assessed gaps in 6 dimensions: geographic diversity, demographics, lived and professional experience, role, organization or sector, and impacted community representation. So based on the experience areas of the continuing members of High Talk, we found the focus areas listed on the slide: behavioral health, community-based organizations and social services, coordinated care organizations or CCOs and health plans, healthcare consumers, including people with disabilities and consumer advocates, people with experience working and living in long-term care, students and youth involved in health IT, geographic representation, especially from rural and remote areas of Oregon, representation from racially and culturally diverse communities, and members of the 9 federally recognized tribes of Oregon. So like I said, we built our outreach plan around these focus areas, and the next slide shows the results of that outreach plan. We highlighted the focus areas in the announcement, which we made available in both English and Spanish. And we sent the announcement to over 60 contacts and organizations that we knew worked in those focus areas, including members of our listserv, which has more than 2,000 subscribers, community organizations, community members, and community partners via networks like the Community Partner Outreach Program, which is part of OHA, and community advisory councils. We also sent it to other internal OHA teams that we knew were doing work in these areas. We know the announcement reached at least 2,000 people, if not more. And then as a result, we were happy to receive applications from 34 people, which is a new record for High Talk recruitment. So the next slide shows how we scored the applications that we received. Our predetermined rubric emphasized these 5 areas: the candidates' interest in High Talk and their experience with health IT, advancing health equity, committees and collaboration, and the recruitment focus areas that were listed in the announcements. We counted professional and lived experience in these areas equally, paying close attention to how candidates described their experiences and related them to High Talk's work. We also conducted some interviews. 2 candidates asked us to meet to learn more about High Talk, and we asked 3 candidates to meet to clarify some details about their experience. On the next slide is the list of candidates that we propose be appointed to High Talk. These are the 6 new candidates, and each one brings an important and unique perspective to High Talk that increases diversity among representation of people in Oregon and relates to High Talk's priority areas in the strategic plan. I want to emphasize a few parts of their experience. Of note, Jess Soltez, the social health director for Kaiser, works closely with community health workers and with community-based organizations, part of Kaiser's CIE and social health work. And when we spoke with her, she talked about working hard to connect with more small community-based organizations and working with community health workers to build those connections so that their network was more inclusive and reached more communities in the area that were not already connected to the bigger community health organizations. I will also want to emphasize that Nick Powers, the Chief Executive Officer of Winding Waters Clinic in Eastern Oregon in the Wallowa region, is an advocate for rural health. And he stated that he would like to be a part of High Talk to help advance the cause for people and reduce disparities. All right, I'm happy to talk more about the candidates, and more information is available on the document we shared. Okay. If it's all right, I'm going to hold questions until the end. I have 2 more slides. So on the next slide, we have the list of current High Talk members that have applied to renew their membership for another 2 years. We heard from Amy Henniger and David Dorr today, the vice chair and the chair. And then I want to highlight that Bill Bard is our consumer advocate. He's an advocate for people living with disabilities and people living in long-term care and supporting family members who live in long-term care. Dave Perkins works for the Yakima Valley Farm Workers Clinic and is a great resource for learning more about rural health. So each of these members have been outspoken advocates during the High Talk strategic planning process, and it would be a great benefit to have their continued insight as we move into looking at what the strategic plan means for health IT in High Talk's work. All right, the final slide speaks to the strengths of this slate. So every one of the new candidates has very strong experience in health equity. They work with communities across Oregon, especially communities that are experiencing crises and strong need for social help. I want to highlight that Jennifer Chi works to advocate for patient experience and digital health equity as part of her work with Care Oregon. And Tyler works closely with a clinic in the Eugene area that supports people who are experiencing behavioral health crises, who are experiencing substance use disorder and are seeking care. And many of the candidates applied for High Talk because of their lived experience using health IT to access healthcare resources in Oregon. Candidates mentioned experiences of discrimination in the healthcare system, experiences helping family members for whom English is not their primary language, of working in emergency care with people experiencing houselessness and chronic diseases, of balancing resources to provide care in rural communities, and helping friends in crisis navigate the behavioral health system. Candidates believe that health IT can bridge these barriers and make healthcare more accessible and effective. So between the new and renewing members, High Talk would have representation from almost all of the recruitment focus areas, and some categories of racial and ethnic diversity would improve. Notably, High Talk would have a member who identifies as Middle Eastern or North African for the first time in the committee's history. This slate also maintains LGBTQIA representation with approximately 20% of members identifying as LGBTQIA. Finally, the proposed membership slate document includes detailed demographic assessments of the group of new candidates and the new group that would result if all candidates were approved. Thank you. We can go to the last slide now for questions.
Thank you, Laurel. Dr. Hemmings.
Hi, hello. Thank you for that presentation. You know, it's interesting as I listen and I hear, you know, work with, you know, various, particular communities, work with people who have these specific needs. And, you know, what I'm thinking about is why not actually have the people who actually have those actual needs or are actually in that community itself, you know, rather than the majority of people who have the power to actually work with. Something else that came to mind was when I looked at your rubric for determining who, you know, how you score the applications. And I was just thinking about, sometimes we need to look at how our rubric actually works to exclude people, right? Rather than include. How does our rubric bring people in rather than bring people out? And when I hear IT, health IT experience, you know, I'm thinking about what does that mean, right? Because if we truly want to bring in the people who are actually, more people who are actually impacted and have the actual experience day to day in their lives, they may not have health IT experience, right? And how much weight are we given to that versus other experiences? I'm not sure if that's something that, you know, you look at when you know, look at these applications. So, you know, I thought of like community health workers. I think you mentioned there was someone there that works a lot with community health workers. And my thought was, okay, why don't we have community health workers then on the committee, right? So that's my pet peeve. I think everybody's probably hearing by now. That's my pet peeve with a lot of these committees. When I see them, it's very centered around power. The people who are in leadership roles, like myself, I don't exclude myself from that, who rather than we're representing people that have needs versus the people themselves who have the needs being on the committees. So that's just my feedback to that. And, you know, hopefully moving forward, I think we need to look at these rubrics and how we score these applications and think about how are we excluding versus including people. Thank you.
Thank you, Dr. Hemmings. Susan, did you want to speak to that at all, or were you just unmuted from? Yeah.
Just briefly, you know, I really appreciate your comments, and I just wanted to mention in terms of the rubric, one of our focus areas and gaps is was looking at direct consumer representation. So people who bring lived experience as patients, as peers, as clients, as et cetera. So when we were looking at health IT experience in our rubric, we were looking at both kind of lived experience, someone that has had challenges or engaged with like their patient portal or had their health information not shared with their, you know, between providers, or if they're a caregiver. So we were not, certainly not excluding people who were bringing the consumer voice and but did not have direct experience as technology professionals, for example. We want to bring in that consumer voice. We're really thrilled to have Bill Bard, who's we're proposing Renew as a consumer member and you know, retired advocate on the as a long-term care ombudsman. And it's challenging to recruit people to a technology committee, but we're trying. And, you know, I think Laurel spoke a little bit about getting the word out to community advisory council members who are representing these perspectives already, you know, that might be more interested. So we'd love to think creatively about how to recruit true consumers. It's kind of what I hear you saying to this committee, and I'm sure other committees on the board. So thank you.
Thank you for that. You know, and I, you know, I'll use myself as an example. You know, someone reached out to me and wanted me to join a committee, a board, right? And certainly, you know, I could, but then I thought about, well, why not? Who do I know that's actually in the trenches with this, right? Who's actually having this experience that I could actually say, hey, why don't you consider this person, right? And I think it behooves us when we're in these positions of leadership and we are the first person to get these invitations, we have access to get these newsletters, we get the invites, you know, that we think about who else could we put forward and not always be the person who has to step up and sit in these spaces all the time. You know, and I'm thinking about the person who, you know, has several employees, for lack of a better word, who, you know, they could actually say, hey, thanks for reaching out to me, but, you know, let me pass this on to someone else, or maybe in sending the invite is to actually word it in that way, right? So then we don't have these meetings and these spaces where, you know, power is so centralized, right? But thank you for hearing me, and I thank you and appreciate the work that you have done.
Thank you, Dr. Hemmings. You know, it also reminds me, you know, in addition to what you just described about the process of recruitment and the invitations to do so, I'm also thinking about the mechanisms of at decision-making moments, much like this, where we understand where the committee itself can evoke that if it's not represented, that we continuously just, you know, almost like hardwire on your decision-making matrix around before you do anything, you're thinking about how do you know, and that can also be useful. So again, thank you for hearing all of this feedback. I know this is not a new conversation for you all, and I deeply appreciate the intentionality that went into it, plus the presentation itself. So I think with that, we're probably ready, and I know we're at time, but ready for an action item to approve the proposed slate for High Talk. Who would like to make that motion?
Tony. Oh, sorry.
I'll second. Tony, I'll second.
Tony and Carly, thank you for note-taking purposes. I appreciate both your motion and your second. Any other discussion? All those in favor signify by saying aye.
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 Any opposed?
Opposed.
Thank you, Dr. Hemmings. Any abstentions? And with that, the motion carries. Again, thank you so much for your presentation, your hard work. I'm glad we got to spend the time with High Talk today. I know such an important, vital part of our system, as was mentioned. So, and appreciate the attention to the board's priorities as well. So thank you. With that, I will help close our meeting for today. As a reminder, our next Oregon Health Policy Board meeting is scheduled for Tuesday, June 4th. This meeting will, as was mentioned earlier, we'll have a little bit of business at the beginning of the meeting, and the majority of it will be set to host the cost growth target public hearing. And as a reminder, this will be held in person and virtual options at Portland State Office Building in Portland. Zoom will be available for those who can't join us in person. We hope you'll be able to be there, board members. The meeting itself will start as per usual at 8:30 in the morning and end at noon. And as always, we'll stay tuned to updates from Tara and the team as we get closer to the date. So thanks for such a great meeting today, and I hope you enjoy your afternoon. Take care. Bye-bye.